Hello, ma'am. Good evening.
I think we should start. Yeah.
Uh, Good evening, everyone. And I'm Dr. Kiran Pandey. I've been past ICOG Governing Council member. And it's my privilege to warmly welcome you all to this FOGSI ICOG online certificate course on perinatal mental health, which is being organized in association with RCOG. And of course, you all know that it is the very important aspect on which we are discussing today. And I welcome all the faculty and the experts. They will be guiding us, all of us, on the evidence based practices and practical insights on the various aspects of perinatal health. And I have important duty to introduce our convener, Dr. Uma Ram. Dr. Uma Ram, as you know, she is director, Sitapati Clinic and Hospitals, and she is All India Chair, AICC RCOG. So I would like to invite Dr. Uma Ram for welcoming our ICOG chairperson and starting the program and welcoming the chairperson of the ICOG, Dr. Sheila Mane.
Thank you very much, Kiran, and welcome everybody to day 2 of this 3-day certificate course. Yesterday we had a very fruitful and interactive session where we had a good number. We had, I think, almost 270 plus logins who were there right till the end, which was very, very heartening. And we had a very good session which focused on aspects of mental health and how that is important across, a woman's lifespan in many gynecological conditions, how we did mental health screening, how do we actually address this issue when we are in the clinic, and then we spoke about mental health in menstrual disorders, in ART and fertility, and then had a panel discussion which closed, kind of brought it all together. Today's session, we are going to address issues that are a lot of focus is around communication in difficult situations. And today we are going to start with talking about perinatal grief, how we, and before that discuss how we break bad news, what is the protocols, what do we follow, which Dr. Ashlisha Bagadia will do. And then there'll be a case-based discussion around perinatal grief. Following that, we have a session on interpersonal violence and trauma and informed care, and a discussion on how do we handle de-escalation and communication skills, because as we all know today as obstetricians and gynecologists, we are dealing with a lot of anger, aggression when things go wrong. And then also a very important aspect of substance abuse will be discussed by Dr. Lakshmi Shiva. And we finished the day with a case-based discussion that will be a panel. So that's the overview, and we will then have the post-test MCQs, which you will have to answer. So with that overview, I look forward to another very meaningful session. And it is my absolute pleasure to invite Dr. Sheila Mane to say a few words. And many thanks to Sheila and to Pratik and the whole ICOG team for giving us this opportunity to present this course. Over to you, Sheila.
Thank you. Thank you, Uma. And once again, I welcome all of you. I don't want to take much time. I think Dr. Sadhna and Dr. Ashok are supposed to address today, the chairperson-elect as well as the vice chair. And I welcome all the governing council members, the delegates, and Dr. Lakshmi Shikande, our ex-chairperson. Thank you for joining, and I think we can proceed. Let us. Dr. Sadhna had joined. I think you can invite.
Yeah, Dr. Sadhna is there. I saw her.
Yeah, thank you, Dr. Sadhna. Can I invite you to say a few words, please?
Thank you, Dr. Uma. ICOG is going ahead with a great team, the leadership of Dr. Sheila Mane and all ICOG team. So mental health is something, a big issue, big challenge, which I think you can stop slide share for the CD. Yes. So in India, actually, that suddenly in the last decade, the mental health issues are really bothering us right from adolescent, from children, we can say, to the elderly age, and a lot of issues are there for its emergence, a drastic change in our ways of life. So this is the utterly needed uh, theme, utterly needed subject where we as a doctor and as a obstetrician and gynecologist. So obstetrician and gynecologists are special because we are general practitioner, like a family physician for them, as well as we are the specialized a person who are tackling the woman in the different phase of the life or the different issues. So yesterday we had a great session, and the collaboration with RCOG is also a wonderful initiative with Dr. Sheila Mane has incorporated, and we actually perceive their point of view as well. So yesterday we had a great session on the screening and how to perceive that this woman or this person is having some issues which need a careful, a really patient counseling and the workup with her personality. And today we are having a very important session. We congratulate Dr. Kumara as a convener, and Dr. Anita Rajoria, Dr. Shashi Kabra, and Dr. Lata Venkataram, who are coordinating all these events, where we are dealing with very, very difficult and sensitive movement, perinatal grief, how to break bad news of stillbirth or IUFD, and the interpersonal violence and the de-escalation communication skill. So these are the skills which we actually, words cannot teach you. And it is your reflection and your sensitivity and your compassion and your concern which make us the skill, or which make us expert in all these sensitive issues. Yet we need the advices, the videos, and the messages from our very senior and the expert people, so that we imbibe these qualities in our day-to-day practice. And today, the postpartum depression, which we thought it is not in India and South Asia, now we are having all these things. So we look forward to a very, very great learning session, and hopefully we all also make an ecosystem in our city, in our clinics, in our region, in our country, which actually prevent the mental health issues. So not too competitive, not too aggressive, not too violent, not to be like a very fast pace, and the patients to look into everybody's emotion with the sincerity. So this is something which we have to do at the very cutting the roots for the mental health issue. So we look forward to a great learning session, and again look forward to your comments and your inputs, and a happy learning to all of you. So thank you very much. So thank you, Dr. Sadhna, for a very kind words about the and appreciation of this course. And definitely, as Dr. Sheila and you said, it is a very important course for everybody to learn, and we have to be sensitive about it. I would now request our very, very dynamic secretary, Dr. Pratik. I hope he is there, Dr. Pratik Namme.
Ma'am, I'm due to speak tomorrow.
Words. Okay. Yeah, so I mean, you are active and doing so many of the good things. So please say a few words.
So thank you very much for the opportunity to speak. I'm scheduled to speak tomorrow. And as I said yesterday, perinatal mental health as well as antenatal mental health are two concepts which a lot of us need to be sensitized about. We need to understand that these are emerging concepts, and that we are not going to be judged only on the positive pregnancy experience that we give our patients during labor, childbirth, and delivery. There are a lot of other components as yet to it. We have not been taught these during our undergraduate and postgraduate curriculum. We are still learning on the fly ourselves, and hopefully we will be able to impart these concepts to our juniors and our trainees as well. Thank you, everybody, for your wonderful collaboration and contribution to the course. I hand back to the organizers.
Thank you, Dr. Pratik. Uh, should we start with the scientific session
Dr.
now?
Ashok Kumar has not joined.
Oh, yes. Welcome, Dr. Ashok.
I think he's, if
Not
he
joined.
joins, then
Dr. Ashok, please say a few words to encourage the participants.
I think he's not there. We'll proceed. Yeah.
I
Okay,
don't see him logged in now.
Are we able to see him? I'm not.
No, he's not logged in now.
Okay. So let's start with the scientific session, Dr. Uma. Should we?
Sure.
I think everybody has already seen the instructions for the more MCQs done later on, and now we'll start with the first scientific session, and which is a very two important lectures on the one on the perinatal grief, and secondly on the breaking bad news. And our chairpersons are Dr. Tamkeen Khan and Dr. Manju Puri. Dr. Tamkeen, has she joined?
Yes, both are there.
Yeah. So Dr. Tamkeen, she is a professor, JNMC, AMU, Aligarh, and she has a very long teaching experience and has lots of awards on her credit, and she's very active. Especially, she is presently president of Aligarh chapter of Ops and Gynae Society and founder secretary of Stillbirth, which is our very found topic. So Dr. Tamkeen is here, and Dr. Manju Puri. May I have the CV of Dr. Manju Puri? Dr. Manju Puri is professor. She is professor in the Department of Ops and Gynae, SGT Medical College, Gurgaon, and she's also has a very her. Yes,
You can
there's lots of
leave it, Dr.
awards and publications, and her field of interest is quality improvement, public health, and perinatal mental health. Especially, she has also edited many books, and I know Dr. Manjupuri, whenever she touches anything, she has goes into the depth. So, I would request the chairpersons to introduce our esteemed speakers.
Thank you, Dr. Kiran, for a very kind introduction. And it is indeed a pleasure to be a part of such a informative and interesting, topic, which is very close to my heart, and it is a very important topic. So our first speaker is Dr. Ashlesha Bhagadia, who is a more than 24 years, and uh, she is going to kind of tell us about the perinatal grief. I think that is something which we are just not aware of it, because we are not aware and we are not trained to diagnose it and also how to handle it. So, this topic and this session is going to be very useful. So over to you, Dr. Ashlisha.
Thank you very much. I'm after a very fruitful session yesterday. I'm very excited about today's session as well. We are going to go into perinatal grief in a minute, but I thought what might be interesting and helpful perhaps is to lay the foundation first with just a little bit of an overview of breaking bad news. I'm also aware that, this is something that perhaps most of you, especially the senior colleagues, would have had a lot of experience in doing this. And, maybe what I'm saying may be very basic. So if anyone has anything to add, please feel free to do so. Um, so remember these, what we're talking about in the context of the next talk as well, because this is like laying the foundation of things to keep in mind when you have to break bad news. And this need not be something like when you have to give news about, say, stillbirth or something major. But even when you have to give information about, say, a dysfunctional thyroid, it's important to keep these things in mind, because sometimes we don't realize that what we are saying, which might be a routine thing, for someone who has never had a health issue, might feel like a bad news. And I remember, a patient of mine felt that when she was told she has gestational diabetes, was devastated. And I was a little surprised as to why was she that devastated. It's quite common now, especially in Indian population. But you never know what can feel like bad news to our patients, especially if they didn't anticipate it. So keep that in mind for anything that feels like you're giving them information that is negative. But of course, today's talk is really focusing on giving the bad news, like a stillbirth or severe congenital anomalies. So which we are going to discuss in the next session. And many of you might have heard of this mnemonic that we use called spikes, which is like a good template to have. S stands for the setting. Who is going to deliver the news? Is it going to be the obstetrician? If it is, something that came up in the ultrasound, does the radiologist end up saying something? And who is going to receive the news? Right now, that is really important, because sometimes it should be the mother and her decision as to who the news is revealed to. Often we also find family members deciding that, okay, don't tell the mother, she'll be very upset, especially if the the baby was stillborn and the mom is not aware of it. So often decisions are made about who will receive the news, which you may want to think a little bit carefully about. And it's always better to err on the side of the mother and make sure she has a little bit of autonomy in this. So thinking about who's going to give the news and who is going to receive the news. Another thing that often you may experience is that, of course, you may tell the mother, or you may tell the husband, and the husband will decide that maybe it's better if the mother hears it from her mother. So he would prefer to talk to his mother in law. And so they may themselves decide that maybe the news is better given by someone else. But whatever it is, a little bit of thought needs to go into who's going to deliver the news. P stands for perception. And again, this I think is something which is almost like bread and butter for all of you. You must be thinking, okay, how much medical jargon does this person understand? Does the patient know? Was this, whatever the bad news that you're going to deliver, is this something where they're anticipating? Especially if, let's say, it's a high risk pregnancy, you've already given them a lot of warnings about what's likely to happen. So they may already be anticipating. And so the information that you may have to give may not be a lot. So being aware of the patient's perception, and especially if it's something is an adverse event has happened around delivery, there are likely to be other people. And or you're giving adverse. I mean, I know we're going to talk about perinatal grief, but this would apply to breaking bad news about diagnosis of cancer. So there may already be other people with the patient, so you might want to think not only the patient, but whoever they accompanying them, what is their perception? What is the perception of the family? Is there any stigma around whatever bad news you're going to give? The commonest thing, especially if there is perinatal loss, is everyone questioning what did the mother do wrong? So you want to keep that in mind as to what's happening in this family, and what is their perception about health issues? How much knowledge do they already have? Are there sort of superstitious beliefs, or just poor knowledge around medications? You should not have taken that medication during pregnancy. Why did you take thyroid? This is what happens. So you want to make sure you kind of have a little bit of a sense of what is the perception of the person you're going to be talking to, and adjust the knowledge to that perception. So you don't want to, of course, I'm sure this is, again, I feel like I don't have to tell you this, but you don't want to make the knowledge so clinical sounding that they get lost in it. And if they have enough knowledge and you've had lots of conversations around what's going on, you also don't want to dumb it down too much, and which can come across as condescending. So you really want to match the level of perception of the patient. Once you have this sort of setting and perception worked out, the next thing is to keep in mind, you know, it's not to just give all the information in one go. What you want to do is work out a system where you are inviting and waiting for them to invite you to give them more. So you invite them and say, obtain the invitation, say, I need to talk to you. This is quite serious. Can we sit down and have a conversation? And you make sure you set a little bit of a stage and say, this is important. And one of the crucial things to remember is that when you're delivering bad news, now there is no way to make that sound good. So, whatever you are giving them, the information is going to be bad news. So, bad news can never sound like good. You cannot change the context around. You only have to make sure that you give the correct information. And when you're delivering the bad news, you have to make sure you don't mince your words and be clear and matter of fact, but give them a little bit of information and wait. Wait for them to absorb it, wait for them to sort of make sense of what you said. Then you say, okay, shall I go on? And then give more information. So it's really important you obtain their invitation not only in the beginning, but also check if they've recognized, understood, assimilated what you've told them. And then if they're ready for more, you can give them more. And at every stage when you're giving information, do this a little bit of check-in before you move on, because then you are not caught off guard by a severe reaction. They also will get a chance to assimilate the information before they move on. Now, the main most important part is what you're going to give them, the knowledge that you're going to give them. And you want to start with a warning shot. Like I said earlier, I have some bad news that I want to talk to you about. And again, when you're giving, make sure you're honest and precise. Don't try to sort of beat around the bush too much. Don't try to sound like you're justifying, or you're trying to put blame on someone else. The commonest thing that you have to try and avoid saying is, if you had come a little sooner, then you could have done something. And that's something you really want to avoid. And you want to be precise in what you're saying. So just stick to the facts at that time, and recognize, often, I mean, all of you, we are all sort of living human beings. We're not robots, not yet anyway. They're still relying on us to deliver care and bad news. So we will have our own history, we will have our own inhibitions around what's happened. We may actually be quite angry with them for not taking care of their health. We may have been upset with the husband who might have done something. So be aware of what your own baggage in relation to this patient you're taking into the room, and see if you can manage that as best as possible. What you do not want to do is blame, definitely not the patient, but also avoid blaming other colleagues. If someone has given them some treatment that didn't work, another obstetrician might have given them some advice that you were unhappy with. Maybe they went somewhere, got some procedure, and then came to you. So the urge will be to sort of try and say, they should not have done this, he should not have done that. And that is something that can come later when they're asking you, okay, what went wrong? Let's look at it. Right now, it's only about giving them the information and helping them absorb the information. So this giving the knowledge and information part is very crucial, that you don't try to justify, don't try to answer any questions just yet. This is only to give them the information. And then the of course the reaction will come. They are completely allowed to feel whatever it is that is coming up for them. And what you don't want is to not expect them to react, right? And you also don't want them to sort of turn the reaction against you. So you give them, you recognize that this is going to be difficult, and you can sort of say, acknowledge if it is sudden. I can see this has been very unexpected news. You can use words like, I'm sorry to have to tell you this. I was also hoping it didn't go like this. We were also expecting a better result. So that is okay to say. Doesn't sound like you're justifying. You can sort of saying that, we were all sort of in one frame of mind, and then this thing happened and we had to shift gears, and we're all sort of dealing with the bad outcome. And so you validate a little bit and wait. Let them express whatever it is. They might cry, they might be upset, they might want to know more. But at that time, resist the urge to fix and answer questions, because when their emotions are heightened, whatever you might tell them will sound like you're making excuses. So at that time, you can say, this is really unexpected. We can sit for a while and wait, till you feel a little bit calmer, and then we can talk. So you allow them to express. And what people, will remember more at that time is how you gave them the information and how you supported them, rather than what you did at that time. So it's really important that you just allow them to assimilate the information and express. And then they might want to know what next. So only after you've done SPIKE, then you think of, okay, strategy and summary. What are the next steps? You wait till they feel ready. You wait till you feel like, okay, they are able to take the information about the next steps. And if it feels like it's too much right now, you say, we'll wait, maybe in the afternoon, I'll come back again, and then we can talk about next steps. You can, have a conversation with your husband, talk to your family members if you want to. And also, always, before even breaking the bad news, ask them, who do you want with you when I'm giving you this information? Or even for the next steps, who do you want with you when we talk about next steps? So asking for their readiness to decide, to have the next conversation is very important. And taking their consent for which family members to include is also very important. So this is another very, very crucial thing. And this again we'll reiterate when we discuss the case, that no matter how much you want, you cannot manage their emotions. If they're feeling sad, they have to navigate that and overcome that. If they're feeling angry, they have to overcome it. So they resist the urge to tell them, don't cry, don't feel sad, think about now, another time you can have a healthy baby. So all those things is sort of distracting them away from feeling what they're feeling, which they have to, and tolerate that grief enough to carry on with the process. So they need to manage them on their own. They need to ride that wave of distress. You can validate it, there are various different emotions, but you just want to help them to guide towards accepting that what has happened, right? And you really want to validate their emotions, but if they become angry and throw things, you can't say, it's okay, I can see you're angry, you can take it out on me. That's not what we're saying. We're sort of saying, this is difficult for you, take some time, when you feel ready, we can talk about next steps. What we suggest you avoid is using words like, I understand how you feel. Even if you've had a very similar experience yourself, in that moment, they are not going to think, no matter how much your understanding is. You can say, I can understand that this must be difficult for you, or I can understand that this must have come as a sudden news. So you're kind of in the ballpark saying this might be something that you're feeling, rather than just arriving at a conclusion that I know what's going on for you. And definitely don't say things like, avoid saying things like, you need to be strong, everything's going to be all right. Definitely using jargon and statistics can drown them in information without them feeling like they have a space to express. Um, another mistake that I've been guilty of, and I'm not sure if others have been, is to kind of compare. See how well someone else handled it. This happens all the time. It's quite common. Many women get over it. So comparing to someone else's grief, no matter how big it is not very helpful, because in that moment, this is the worst thing that can happen to them. So these are the things to try and avoid. And of course, the crucial part for you when you're delivering bad news, it's not that you're having a good time. So have a colleague available for support. You might be going through a lot of emotions. You might have held this person through their entire pregnancy. So they almost become like part of, your family, your day-to-day work life. So you also will be experiencing grief. So manage your own emotions as best as you can. Debrief after every session, or talk to someone you trust. Having different type of case discussions, different scenarios with your team can be helpful. And we'll be dwelling more on this theme next tomorrow, about looking after yourself. That's very important as well. So that's the end of my talk. Thank you. We'll move on to the next one. I just wanted to check if anyone has any questions or comments before we go to the core discussion around perinatal grief.
Yeah, so thank you, Dr. Ashlesha. So it was a very, very crisp and to say a systematic approach to breaking the bad news. And what I would like to share from my side is that, just to know the theory may not be sufficient. For obstetricians, it is important that we have some kind of role plays, you know, and do some role plays and then kind of get into, how to do that, because it is a very uncomfortable situation. Even the senior most person would feel very uncomfortable and, inadequate.
Have we, sorry, I can't hear.
So thank you very much. And yeah, so maybe we can shift to the next talk. Dr. Tamkeen, in case you want to say something.
I think Dr. Ashlisha has covered the principles of breaking bad news very nicely and also shared her own experiences. I just like she was giving the example that she thought that now she thinks that was not the right way of saying something. So there is no right way, there's no wrong way of doing it. We learn with experience. But there is this spikes framework or ABCD, there are many frameworks on which we can train ourselves. And also, it is also whenever you are trying to break news, you have to keep the cultural, the religious context in mind for that particular family that is there. So that is very important. So we need to learn with time, explore, and also learn the principles that are there. So thank you very much.
I think regarding the role play, I think Ashlesha, if you have any video, something like that, we would like to put it on our ICOG website. So
We do actually. So we have a video recording which we will share as part of our resource pack.
Yeah.
Where someone is breaking bad news. It's a role play with Dr. Lakshmi Shanmugam. I think you might know her. So we'll definitely share that as a resource.
I think Shashi Poonam, you have to unmute Dr. Shashilata Kabra. Thank you. And thank you, Dr. Manju and Dr. Tamkin. Yeah, I think that's very good. Thank you.
Which I would like to also add on is that the senior most person in the team should be breaking the bad news. Always. We should not leave it for the senior most person. So on to the next one.
Yeah, that's a good point, actually. And in the later on, I'm talking about communication skills. One of the things also is that when something like this has happened, especially an adverse event, seniors, you might also want to look after the impact on the juniors. They may not understand what they've experienced. So one is, of course, it's very noble to say that the senior should go ahead and break the bad news. But even after breaking, even if the juniors have not done it, the impact of an adverse event can be there. So looking after them also can be very helpful.
Yeah, thank you so much, Dr. Ashalesha Bagadia. So, thank you so much for such a good talk on breaking the bad news. And now we have the next session. Next topic is perinatal grief, and it will be taken by Dr. Ashalesha Bagadia and Dr. Vara Lakshmi Nandial. So, may I request the IT person to display the slide of both the speakers?
I've been introduced already, so maybe Dr. Varalakshmi
Ma'am,
can
you are so well known.
um,
So I'll introduce myself. I'm Dr.
Yeah, please, ma'am, you please introduce yourself.
Yeah, I'm from Hyderabad. I work in Rainbow Hospital, and I've been a part of the perinatal mental health course. So I would like to thank the ICOG organizers and our beloved mental health course team, Dr. Umaram and Dr. Prabha and Dr. Aslesh, who has put it so beautifully. So it is a very practical course where we are, discussing the case-based discussions. It's not like didactic lectures, but it is a very practical course, which is extremely important for our obstetricians. So today, I think we can start sharing the slides. Yeah. Myself and Dr. Aslesha will be taking you through the perinatal mental health. How do we handle sensitive handling of perinatal grief and loss, which is a very important topic to the obstetricians. It has a profound
Can you make it full screen, please? Sorry for disturbing. Full screen. It's not. It's on slideshow mode.
Yeah, please.
Is this
Yeah.
better?
Yeah, thank
Yes,
you.
yes.
So, perinatal grief, it is a very complex situation because it has a profound impact on the not only the family, the couple family, but there's a lot of distress, like Dr. Aslesha was saying in her talk, that none of our clinicians want this bad outcome for our patients. So there's a lot of distress to the obstetricians as well. So we are, as obstetricians, we are all well versed with dealing with clinical situations. But in this scenario, it is also very important. The communication skills extremely important, and also taking them through this process of grief is very important. So coming to some definitions, grief is an emotional response to loss. Like initial, they may go through phases like shock, anger, guilt, and anxiety. Whereas mourning is the process that one goes through to deal with these emotions, and bereavement is a time period during which the grief is being resolved. So, with these definitions, now we are going to I'm going to discuss a case, and then Dr. Aslesha will be talking about like how do we communicate some situations from and help us with these cases. So I'm sure most of these cases obstetricians would have gone through. So let us see. This is a patient who is a second gravida. Previous in first pregnancy, she had an emergency C-section at 38 weeks for meconium stained liquor, and she had an uneventful delivery. It's a girl baby and a healthy baby, now 4 years. Present pregnancy, she's booked and immunized, and at 28 weeks, she was diagnosed with gestational diabetes, and she was started on insulin. So on regular follow-up she's on regular follow-up with the obstetrician and diabetologist till 32 weeks. So at 37 weeks, she presented to the OPD saying that for the last 2 days, she was not having good fetal movements. So on examination, it was irritable uterus, and we did a bedside. We tried to locate the fetal heart with Doppler and could not locate the fetal heart with the Doppler. And then we did a bedside ultrasound where we could not see the fetal heart. On local examination, there was a meconium stained liquor, and the bedside the glucometer blood sugar reading was 201. So this is what is we found. So initially, when like breaking bad news has already been discussed by Dr. Aslesha. So with all care, we had to break the bad news to the couple when we saw the scan findings. And the couple were in shock initially when we said that there was no fetal heart, and there was different reactions from the husband and wife. The father was there; he was very angry, saying that why did this happen? We were having regular antenatal checkups. Was there any fault in? Did you not diagnose it earlier and things like that? Whereas the mother, the woman, was very blank. She was very confused, and she kept saying that she felt the fetal movements. She could feel it, although it was reduced. She could feel the movements till the time she came to the hospital, and then she started crying. And they wanted a reconfirmation. They could not believe that there was no fetal heart, and they wanted a reconfirmation. So we took her to the fetal medicine department, and they did a scan, and they confirmed, and they showed the findings to the couple. So while counseling the mother later on, when husband was not there at that time, she quietly was saying that she stopped taking insulin and monitoring her sugars for the last 2 weeks, and she was very guilty about not taking the medication properly. So now that we have seen how to break the bad news, the next step is that Dr. Aslesha, could you just take us through how do we sensitively communicate this to the couple, because there are mixed reactions. The husband is angry, the wife is very confused and very started crying and depressed. So how do we handle this situation? You're muted, Aslesha.
Then, Sorry about that. I didn't realize someone had muted me. Yeah, I'll go back to sharing. So if people can just leave whoever is managing tech, can you just leave me as unmuted? So thank you for sharing that case. Oh, hang on, I'm sharing the wrong one. So it looks like you have done everything right in this situation, isn't it? You tried to make sure that the initial news, there was some warning, there is some information that was given to them that maybe something is happening. So you have tried your best, but this is a crucial thing to remember, that you will do your best, but there'll always be something that will set them off. And they are definitely in a situation where their emotions are heightened. Something has happened that has ticked them off, and they're trying to find an answer. They're trying to perhaps also find whom to blame. So when you are looking at balancing the communication, the crucial thing is take a few minutes before jumping in. What we feel like doing in that moment is immediately respond, especially there's anger. And I know, the situation in India is so horrible right now that there is concern around like a mob gathering and, people sort of blaming the doctors for everything. So before you respond to them, take a few minutes. And especially if you've been called in, for example, like someone said that if your junior is handling the case, then make sure you go and break the bad news. So you may not have the full information before you go and deal with this family. Someone may be saying, oh, we told the husband and the husband is asking for more things. So find out all the facts of the case before you jump in. And definitely, if you've got information in this, the mother reveals later on that she had stopped taking her insulin. So resist the urge to throw her under the bus. Avoid blaming her in front of the family. If you're concerned about her behavior, definitely she needs education. So you can address it separately with her. But in this context, make sure you don't tell the husband, it was not our fault, she stopped taking insulin, because then you kind of lost their trust. And really, whatever her limitations might be, it needs to be addressed directly with her. In this situation, especially like in one of my previous slides, I had said something like, say that I'm sorry you're feeling this way, but be careful not to apologize, especially if it is not your fault. And again, saying sorry for when it is your fault is a different time and place for it. In this situation, you really want to say, really sorry that this has happened. So you're apologizing for the outcome. You're not apologizing. You're actually saying, I'm sorry. I feel this. You're sympathizing. You don't want to say, I'm sorry, I made a mistake, not when there are heightened emotions. So you're not, this is not the time to do that, even if you're feeling bad and guilty. So the balanced communication is really, again, allowing them to express, they want to know what's happened. You give them all the facts that you can, and you say that, up until this point, this was going on. When you came in, this is what we felt, and we noticed the stained lacquer, and we realized that something must be wrong. And you give them the factual knowledge of what you know, as best as possible, allowing them to express their distress. And of course, if the distress is directed at you, it's all right to set a little bit of a boundary and say, it looks like this is really upsetting for you. I'll give you some time. And if you want, we can go and sit down and talk in a room quietly. So make sure that you are uh, not walking away from them because they're angry, but you're saying, we'll talk again. If you want, we can go to another place and talk, or I can come back in 5 minutes. So you're not walking away just like, I can't do this. You're sort of saying, we'll come back and address it. So you want to do that balance between setting boundary, but also being empathetic. Over to you, Dr.
I think
Varalakshmi.
that's very important that we should not be too defensive in these situations and start explaining too much to them. like you said, the facts needs to be explained, and the other thing is that not blame the woman saying that, oh, she did not take. Those things are very important in this. So now that we have did the breaking of bad news and all that, so the next most important thing where we have to be very extremely careful is how do we sensitively handle these women at the time of delivery. That is also a very important aspect. How not only us but the entire team who is taking care of the women, like the nursing team, the people, other people in the labor room. So it's very important. So can we just go through about how do we sensitively handle at the time of delivery?
Yeah. The most important thing, which I think, just listening to everyone's conversation yesterday and today, I feel like this is something that is already present a lot in the audience that is there today. But it's really important to continue to maintain or help maintain the dignity and respect for the mother and for the baby. And often you want to sort of make sure the mother makes the decision, especially in things like, does she want to see the baby's body after delivery? Do they want to take pictures? Now, I know in some situations the husband takes a call and says, no, 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 she'll be too traumatized. And maybe that is something that the family may decide. But I know some hospitals take photos of the baby so that if the mother changes her mind later on, or if she then later on feels bad, oh, I should have been allowed to see, then maybe the photos can help. But as much as possible, if you feel like the mother is in a good position to make that decision, allow the autonomy. And like you pointed out rightly, Dr. Varalakshmi, that sensitizing the team, because it's not just you, there are other people who cleaning the body of the baby, there are other people who are involved. So make sure that everyone is sort of on the right page. Sometimes a well meaning colleague who may be trying to protect you, may want to say, well, it's not the doctor's fault, may come across as insensitive because they feel like, it's my duty to protect my doctor or my nurse. So just be careful that in that urge, you're not losing sight of, what the grief that the patient is going through. So sensitize the team that at that time, the priority is to manage the next steps with dignity and respect. And sometimes it's also helpful to have a checklist. What do I need to do? Who do I need to take consent from? What's going to happen next? Because and even the thing about breaking bad news, having a checklist is helpful because when emotions are high, also when you might be perhaps racking your brain as to what could I have done differently, even though you've done everything right. So your emotions may also be preoccupied. And another common thing that can also be happening is there might be another labor waiting, there might be another something happening. So you might already be thinking about the next emergency that is there on your hands. So often our mind will be distracted with something that's impending, something that you might have done wrong in the past. So it's important to sort of see if you can bring yourself back to this situation and address what is required here. Very difficult task. And every time I give this talk or talk about these things, I just can't help but amaze at how hard it is and how you must be doing this all the time. So in those brief moments, sometimes it's easy to forget and start prioritizing other things. So have a checklist, and maybe this will help to make it a little bit more sensitive experience for the mother.
Yeah, also in obstetrician, like we have busy labor wards. It's also important for us to keep the women separately, not among the other laboring women, where she'll start getting very emotional listening to the cry of the other baby child born. So as much as possible, if it is feasible, it is better to keep her separately and not among other laboring women. I think that is also very important. And in our Indian setup, they may not. The most common thing that we see is that they would want, most of the women would want to see the baby, but then the family members will say, "Don't show the baby to the mother because
Exactly.
she might be." So I think if she really wants to see, I think we should go ahead and explain the family and show the baby to the mother. They may not
Yeah.
want to take photographs or finger those footprints and all, but at least they would want to see the baby, and I think that should be respected.
Yeah. And I mean, also be mindful that sometimes, like I said earlier, that there can be a lot of blame to the mother. So her decision making sort of autonomy is taken away from her because elders in the family must be thinking she's at fault. So they may be stigmatizing her and not necessarily coming from a place of empathy for the mother. They might be sort of thinking she shouldn't be seeing the baby, she's caused the harm. So really, talking to the mother separately for a few minutes will give you an idea where she's at, and not caught up in the emotions of the family as well.
Yeah. So let's go on to the
Go on
next
to the
case.
next case.
Yeah. So this is another common scenario we see. This is 25-year-old Primey. She's been admitted for elective induction of labor at 38 weeks. She's a gestational diabetes on insulin. She was booked with us at 6 weeks, and she's a very extremely anxious personality. She used to come multiple visits to the hospital, even unscheduled visits, saying that she has some non-specific pain or some complaint or the other. She used to come even on her otherwise from her regular visits also. And she was diagnosed at 28 weeks with gestational diabetes, and this made her more anxious and more concerned about her pregnancy and well-being of the child. And so she was induced with misoprostol, and labor analgesia was given. For epidural labor analgesia was given. Progress of labor was monitored, and at 9 centimeters dilatation, there was a sudden fetal bradycardia. So we had to just rush her for an emergency crash cesarean section. And on cesarean section, where it was noticed that there was rupture of the uterus, and it was a prolonged surgery which was done under general anesthesia, and she had to be transfused. A blood transfusion was needed. So, she had a female baby, which it was a severely asphyxiated baby, 2.3 kg. And the baby was intubated and admitted in NICU because of the poor condition. And the patient was not aware of the baby's condition till the second post-operative day. The family insisted, saying that they didn't want the mother. She knew that the baby was in NICU, but she doesn't know that the baby is so sick. So baby had multiple complications, hence extensive neonatal counseling was done explaining the guarded prognosis. And on the third post-operative day, couple had to make a decision. Because of the guarded prognosis, the neonatologist counseled them, saying whether, because of the risk of long-term morbidity of the child, whether they continue or withdraw the supportive care. It's a very difficult situation where they usually in these situations the patients, the couple comes back to the to the obstetrician saying, what should we do, doctor? So it's a very, very difficult situation. It's difficult for us to make a decision on their behalf, but at least we should do a good job about counseling them at this point. So family's emotions when dealing with very sick newborn and a sick mother is what we want you to take us through.
Yeah. So this is such a difficult situation, isn't it? It's almost like you have to break bad news several times as you're navigating these stages. First you have to sort of say, okay, there's distress, we have to take for C-section. Okay, there's uterus rupture, we have to do something now. So it's almost like you have to give them bad news at every stage and allow them to assimilate that information. Of course, that's not very helpful at all. So you still have to remember that every time you give them a bad news, it feels like a fresh sort of assault on them. And you are also experiencing a roller coaster, so you have to anticipate them experiencing a roller coaster as well. So when they are very, they within a span of couple of days, they've gone from, being oblivious, happy, pregnant, expecting the baby, to a crash of, maybe the mother and baby both are going to die, to then, okay, maybe it's in NICU, it's not going to be that bad. And then now the baby's on ventilator breathing, then the next crash. So if you have to be mindful that this is just a complete upheaval. And so it's all right to state that as well, and to sort of say it's been, such a tumultuous time, but we need to make a decision. You want to tell them that, this is something that you can take your time, but also sort of say it'll be helpful, if you want to ask more questions around this, I'm happy to address the questions. So you're not sort of giving them indefinite time, which can be quite overwhelming as well. So you allow them to express their emotions, and also wait till they're able to discuss it and ask you what to do next. Another difficult part here is that the husband may have to make these decisions while the mother herself is quite sick and may not be fully able to participate in the decision making process. And the husband might be cognizant that he's having to make a decision with a mother who's compromised and vulnerable, and that can also be difficult. So you have to be careful not to put pressure on them, but also sort of be around them, vigilant enough for them to respond and make a decision. I don't know if you want to, do you want to add anything, Dr. Varalakshmi, to this before we go on to the next part?
Yeah, I think it will be also useful to go along with the couple into the NICU, talk to the neonatologist, see the baby, what the condition is, what the practicality is, and then it'll be easier for them to, I mean, I wouldn't say easy, but at least they'll have a clarity about taking a decision. Because having a long, first of all, the prognosis they said is guarded, but then having a child with the long-term morbidity, so all those things I think they should take into consideration before taking the decision.
Yeah. And I guess, like you said, no, so it's important to give them as many facts as possible without pushing towards one way or the other. Our own beliefs may come in the way, so you'll be very careful that they should not feel like they have to get pressurized, but really, address the pros and cons. Another thing to keep in mind here is that often there might be influence of extended family. So it's really important that you give the couple time on their own, away from sort of other people, so that they get a chance to think about what they would like. And if they feel like they need to consult, their parents or whatever, maybe they can go ahead and have a conversation, but to come back and really make the decision on their own, because only then they'll feel like they made a call. We've had so many sort of, people coming back later and saying, oh, I was forced by my parents, and my mom said this, and my dad said this. I didn't know what to do. I was so confused. So just giving them time to feel comfortable with their decision is more important than them doing what feels like is a correct decision. They need to be okay with whatever they've decided.
Yes.
So I guess we haven't got time to do more cases, but there are other experiences that you've had, isn't it, Dr. Varalakshmi, of mothers, if they've had an experience like this of having lost pregnancies and subsequently they're coming for next pregnancy.
So especially in early pregnancy loss, what we commonly see
Dr.
is that
Varalakshmi, can you be a little loud, please? Because someone is saying your voice is
my
soft.
volume is full on.
Closer to the mic. Closer to the
Yeah,
mic.
yeah. Closer to the mic, please.
Okay, am I audible now?
Yes, yes, you are. Yeah.
Okay.
Yes,
So-
ma'am. Now better audible.
Okay, thank you. So the other common thing we see is that in early pregnancy loss, many a times we see that the women after early pregnancy loss, we just don't give them enough attention, because some women really go through a bad phase even after. Because one lady was telling me that that she was very depressed after having a miscarriage, but then everybody kept saying it's not a big deal, you'll conceive again, and it was just brushed off, saying that so I think early pregnancy loss is another important thing, and we should also maybe when we have a clinic, when we see them after the pregnancy loss, after the miscarriage, when we see them for a scan or something, we should also go through how the mental status of the women is, and if they're fine, you don't have to, but then I think that one question is very important for us to ask them, so that we identify these women.
Absolutely. And I think sometimes, again, like I said, it feels like such a common thing. I mean, I've had, when I take history of pregnancy loss, sometimes women themselves will say, yeah, I had one miscarriage at 6 weeks or 7 weeks, something. They also don't take it seriously sometimes. So I think generally, if a woman experiences grief when she's had an early pregnancy loss, people around them may not take it very seriously. So it's important to take not just the history of a miscarriage, but how did that impact the mother? How did it impact her? How is she entering this next phase of planning for pregnancy or next pregnancy? Is there anything left behind lingering from that previous pregnancy loss? That's really important. And we can use some of the screening techniques, screen if there has been any sequelae of that loss. Has it impacted them, impact their functioning to such an extent that there is a lot of anxiety, there is a lot of delay in planning for the next pregnancy. Either they are reassurance seeking excessively, or they're avoiding I had a patient who was given bad news after her previous pregnancy, and it turned out to result in a stillbirth. And so the next pregnancy, she was avoiding going to the doctors and avoiding so that she would not get the bad news. So they can have behaviors that can result out of the trauma, which is important to keep in mind. I think that's so one of the things we want to sort of leave everyone with is this learning point that bereaved parents never forget. They might, of course, they'll remember the loss that they experienced, but they will never forget the understanding, respect, and the genuine warmth they received from caregivers, especially, how they were treated at that time. That becomes the lasting and important memory. So this is really important to keep in mind. Many people will tell us that how sensitively the obstetricians took care of them at that time stays in their memories for a long time. So I hope you remember that, and with that we will stop this.
Yeah. Thank you so much, ma'am. It was perfectly in time, and it was a wonderful and excellent discussion. In fact, we knew about many insights of this topic, and today we have two very learned and experienced doctors, Dr. Tamkeen Khan and Dr. Manju Puri, ma'am. I respectfully invite them to share their valuable insights, views, and words of wisdom on perinatal grief.
So
Manju,
thank you,
ma'am.
Shashi. Yeah, thank you, Shashi, and thank you, Dr. Ashlesha and Dr. Veera, for excellent crosstalk and making very pertinent points, which are actually very relevant to the obstetricians. Uh, uh, I'm saying very difficult situations which you have shared and kind of helped us understand as to how can we navigate through these difficult situations. Uh, what I want to add on is that it is not only the mother, we also need to take care of the father also, the partner of the woman. Because what happens is that conducted a study wherein we found that even they were devastated. So they are supposed to be strong and not kind of participate. So it has to be the couple which should be taken as a whole. And secondly,
Can I just add
the early
Dr. Manju,
pregnancy losses.
also the siblings as well.
Yeah, the
How
siblings.
do you
Yes.
tell a 4-year-old
Yes. Yes.
who's expecting that a baby will be coming back home?
Yeah.
So,
Correct.
Yes.
rightly said, the father, and of course, yeah.
Yes. And I guess that we all should have those PHQ4 or PHQ9. They're very simple tools which we can kind of, I don't know, I hope I'm correct when I say that you can apply
Yes,
those
yes,
and just ask,
absolutely.
just ask those questions and find out how they are feeling. That's it. And in case they need assistance, we should be referring them. So our job is not to treat them, but identify them and refer them to the right place so that their, anxiety and their mental health issues are resolved so that before they go into the next pregnancy. Thank you very much. It was indeed a very, very useful conversation.
Thank you
Thank you.
so much, Manju, ma'am. And now I request Dr. Tamkeen Khan. Ma'am, she has a lot of experience in this. And madam, really, we are grateful and we are honored that you are with us. Please, your
Thank
words
you
of
so
wisdom.
much, Dr. Sheila and Dr. Shashi, for involving me. Like I said, there's no right way or wrong way of doing it. If we work within a framework and we practice, make a conscious effort to do it properly, we will learn with time. Uh, there are very few studies. Till 2016, very few studies from LMICs of what's the correct way of doing it. And then only in 2019, the RESPECT study came. That was basically a consensus statement on the 8 principles of breaking bad news, or especially in reference to perinatal deaths. So basically, we need to reduce the stigma and deliver the news in a non-judgmental way. The respectful care should involve the baby as well. I remember coming out of the labor room and the father asking the ward attendant, please hand over the baby to me. And the doctor saying, look, the other attendant saying, look here, should I be concerned about the live babies? It's such a busy labor room. Or should I waste time in handing over your baby to you? So you just wait. So the respectful care includes the baby as well. And then, of course, the support the family emotionally and help them make decisions. That is most important. So difficult for them to decide about autopsy and other things. So just guide them towards it and then acknowledge their grief and the personhood of the baby as well. Then also provide information and contact numbers, and also most important, the part of that, those 8 principles is that bereavement care should be delivered in a social, cultural, and religious context. And then earlier, Dr. Ashlisha was talking about saying sorry, and rightly pointed out that in our, in our society, saying sorry means that you've done something wrong. So remember, when you say sorry, what is she understanding? So what you are saying is not important. What you are communicating to her and what she's understanding, that is more important. So though if you can commit a mistake, evidence says that it is best to say sorry if you commit a mistake. Then, of course, we talked about place of delivery. So, very recent incident in our labor room. I was going into the labor room, and the residents were all worried about the fetal heart of the mothers, the mothers with the live babies. And one mother said, "आप लोग मुझको इसीलिए नहीं देख रहे हो ना क्योंकि मेरा बच्चा जो है वो खत्म हो गया है." I felt so bad for her. So that is very important, that when we are delivering them, we are conscious of the fact that ideally they should be delivered in a separate place. But if it is not possible, then at least we should be sensitive to their needs. So thank you very much. And I
Yeah.
think so many people, like 185 people, have joined. So that's really great. That's an achievement, Dr. Sheila. So many people have been sensitized to this very important topic.
Yeah.
I
Thank
invite
you
all
so
of
much,
you to
Dr.
be part of Silver Society of India, 2,500 rupees life membership.
Yeah. Thank you so much, Dr. Tamkeen Khan, ma'am. And in fact, I want to share one thing. I attended one of the seminars, 3 days CME seminar on bioethics organized by NB, and they do a role play on how to break the bad news. All this, I think that should also be encouraged. And now, can we have questions? I'm reading out the questions, and I request the speakers to please.
I
I've
think questions
responded to
can
one of
we
them.
take it in the chat box so they can answer there.
Yeah,
We
yeah.
can answer here in the chat box.
Okay, okay,
We
right.
can carry on.
Yeah.
We can proceed.
Yes, yes. So we can proceed for session 2. Uh, the chairpersons for our session 2 are Dr. Jayarani Kamraj and Dr. Kiranmai. Uh, please, yeah. So it's my proud privilege to invite Dr. Jayarani Kamraj. And Madam, it's really good to know about you when I talk to you about this program. So she is a senior consultant of reproductive. Please go back to the previous slides. She is a senior consultant of reproductive medicine, infertility and sexual medicine, director at Akash Fertility Center and Hospital in Chennai, and she is chairperson FOGSI committee, No Violence Against Women, 2026-29, president-elect TAPISAR, Joint Secretary FOGSI, many advisory council member, World Association. Ma'am, we are honored and pleased to invite you here as a chairperson. Next slide. Dr. Kiranmai Devinani. She is a professor and head of the department of OBG at GMC Vanapati and at Kaloji University of Health Sciences, Telangana. And she too was chairperson of the same committee, No Violence Against Women, 2022 and 25. And she is a core member, coordinator, trainer of trainee, and faculty of Dhira Initiatives, top. And she received the Kamini Rao Yuva FOGSI Orator Award in 2013 and FOGSI Dhira Award in 2021. MS Signature Award. So I request the chairpersons to introduce the speakers.
Chairperson not joined yet, ma'am.
Okay. So may I invite the
I'll introduce.
yeah,
Shashi, don't
speaker?
worry.
Yeah.
Yeah.
Okay.
It's our privilege, yeah. May I do the honors, Shashi?
Yes, you are most welcome, Dr. Anandita. You always come for help.
Yeah.
I was there, Shashi. You
So,
just
Dr.
actually you started. Deepa had said. Anyway, please introduce.
Yeah.
So,
Yeah.
Dr. Lakshmi Shiva is the consultant psychiatrist at RCOG Neuro Psychiatric Center, Bangalore. She is DPM MD from NIMHANS and postdoctoral fellowship in women's mental health, NIMHANS Bangalore. Over to you, ma'am. You have done a lot of work at various centers, and we are fortunate enough to listen to your presentation. Over to you, ma'am. Yeah.
Sorry, I'll wait for the other speaker also to be introduced.
Yeah. So the other speaker is Dr. Uma Mikilinani. Ma'am, it was great talking to you when we were inviting you here. And she is MD FRCOG Fellowship in Fetal Medicine and is currently the lead consultant Birthright by Rainbow Hospital. She is the president of APRCOG Trust. So over to both of you for your conversation, your crosstalk.
We are waiting for a wonderful session by both the speakers.
The sessions are going so well, Shashi. Congratulations.
Thank you. Thank you.
Yeah. So can we begin?
Yes,
Yes,
ma'am.
yes, ma'am.
Okay. Okay. I'm just sharing my slides.
The delegates can post their queries in chat box. It will be
Yes,
answered in
yes.
chat box, or if we get time, we'll discuss them at the end of the sessions. And please wait
Is it
for
visible?
the post
Yes,
at the
yes, it
end.
is
Yes,
visible,
ma'am.
So
ma'am.
please try to
You
attempt
full
here.
Put it on
screen.
slideshow.
Slideshow, please.
Yeah.
Yes.
Yeah, perfect.
Yeah. Is it fine? Yeah.
Yeah, it's visible.
Thank you all.
Okay.
Okay. Good evening, everybody. It's my pleasure to be here with my co-speaker, Dr. Uma. So today we are talking about interpersonal violence and trauma-informed care. Just to introduce the topic as to, why it is important to understand violence for obstetricians and gynecologists. In general, there is people think that pregnancy or postpartum are protective periods for women, with regard to violence. A lot of people feel women get more care during perinatal period, and therefore the violence is actually less. But what we see is it's not necessary that violence is less. Yes, in some women it may reduce, but there are also cases where actually violence increases for women during their perinatal period. As we know, interpersonal violence includes partner violence, that is intimate partner violence, and domestic violence. Why obstetricians? Because I feel you people are, you have a unique place in this topic, because you are the only healthcare professionals who a woman is in contact throughout her reproductive, years. And so if at all there is somebody who she is probably open to talk to, it could be you, if she gets the right kind of stage and response for it. But the truth is that no woman will come and directly say, I'm facing violence, please help me. I think those kind of women would go to the police or take legal help if they have so much of courage to do so. The kind of population probably who you will encounter are the ones who are not very vocal about it, but we'll have to be sensitive and to pick it up or to respond when something like that comes up. So this is what we are going to talk about in our presentation. Uma ma'am?
Yeah, thank you. Thank you for letting me in here for this topic. Thank you, ICOG. Now, as we move ahead with our discussion on interpersonal violence or violence, domestic violence during the reproductive age group of women, we'll first discuss about a case scenario and take it from there on. So this lady, a 21-year-old, presented in her second pregnancy at 24 weeks with complaints of backache and pain abdomen. This was her first antenatal visit with me. Her obstetric history: first pregnancy was unbooked. She had vaginal delivery, or female child, birth weight not known, and it was a home delivery. Unfortunately, the baby died on 16th day, cause not known. Going into the social history, she's married for 3 years, living with her husband and in-laws. Husband works in a factory as a daily wage laborer. She discontinued her school at 10th standard and is currently unemployed and completely dependent on her husband and husband's family for finances. Her parents live 200 kilometers away. Husband is alcoholic. And looking into this whole situation, I took it as she has poor support system at home. Now, in this current pregnancy, this is her first antenatal visit, and she is already 24 weeks. So, needed antenatal care was provided to her as a part of a booking visit. On examination, her BMI was just 20. She was anemic. Her hemoglobin was like 7 grams per deciliter. And apart from obstetric examination, abdominal examination showed a burnt wound 3 to 4 centimeters, which was in the healing phase. It was not fresh. Looks like maybe 2 to 3 weeks old. On inquiry, she mentioned that it was accidental during cooking when she had splash of water on her tummy. On inquiry, she mentioned that she was accompanied by her brother-in-law's wife, a co-sister, and she mentioned that it was only a burnt wound, and she was not expressing herself well, scared of the hospital environment, and feeling very anxious, and was very concerned about this baby because, in view of her obstetric history, we thought, yeah, she's anxious about, current pregnancy and the fetal condition. After finishing her first visit and all the booking investigations, we gave her prenatals and scheduled antenatal visits. So after that, she had many unscheduled antenatal visits, like here, there. She never was compliant with her antenatal visits. Maybe she had a total of 2 to 3 visits in between. And each visit, she was complaining of vague symptoms like, backache, pains, sleep problems, disturbances, tiredness, which we generally think it as, kind of obstetric patients complaining of vague symptoms. Now, at 35 weeks, she came back with the history of fall. She says she had a fall, but on evaluation, we noted that there is a Colles fracture. She was admitted and treated in collaboration with our hospital orthopedician. Now, given this case scenario, Dr. Lakshmi, can you tell me what are the factors that are indicative of, kind of red flags for domestic violence? Should we suspect domestic violence in these situations? And what are the factors that indicate the need for psychosocial assessment?
Yeah, thanks, Dr. Uma. I think this case is, it exemplifies a lot of things that we usually want to look at in case of suspected domestic violence. The fact that she had a burn mark, she had a wrist fracture, so indicates that she's having frequent injuries. Her first as well as her second pregnancy are unbooked, right? You did not get sufficient details about the first pregnancy also. And even now, it's only at 24 weeks that she came first. After that, also, it was not like she was very regular. There was a history that there was a death of the first child, and it was a female child, but we do not, again, know why exactly, what is the reason, very little information about that as well. Poor social circumstances, you're right, like you said, she has poor social support because her parents live quite far away, and then husband is alcoholic, he is also a laborer. She herself is not, well educated. She doesn't have financial independence, and so these kind of things. And she appears quite anxious and apprehensive of the hospital environment. She's seeming to be, having some distress, which you don't know what it is about. Sometimes patients keep lingering on even after their consultation is over. where you do not know why she is standing there. Probably they want privacy. Probably they cannot talk, when they're accompanied by a relative, especially if it is like mother-in-law or co-sister in this case, they may not be able to talk about what exactly is happening at home. So, and substance use in the partner, like I mentioned, husband has alcohol dependence. So all these are, markers for us to think that there could be something else which this lady isn't probably sharing. Yeah.
So, as you mentioned, it's not that easy to get a history of domestic violence from the patient. So, what are the barriers to the woman to tell us about the domestic violence, and also the barriers from the professionals, to side to get into, into the shoes of the patient to get history of domestic violence. So, barriers from either side, So,
Yeah.
get the full details
Yeah.
of the patient should admit. So, what are the barriers in between patient and doctor?
True. A lot of times, domestic violence or intimate partner violence goes unrecognized in our routine antenatal care. We don't pick up at all, even though the woman is coming for regular care, even then we don't pick up. That's because, like you said, a lot of barriers from the woman's side as well as from the professional side. So let's look at what are some of the barriers that women may have. Very important is the hidden nature of the domestic violence itself. um, they consider it to be shameful. They do not want to talk about it, and they feel people don't understand even if they talk about. So there's a lot of shame and guilt and those things attached to it, because of which they may not talk about it. Not understanding this is abuse. A lot of women normalize abuse. According to them, oh, this happens in every other house. Probably I have seen my father beating my mother. I've seen my father-in-law beating my mother-in-law. Neighbors, in the neighbor's house, husband is beating his wife. So this is normal. And why should I go and talk about this to the doctor? Fear of consequences. A lot of time women feel if they talk about it, violence may actually increase. In case if the partner is accompanying, or say mother-in-law, somebody, if they get to hear what she's talking to the doctor, they feel that disclosure will result in further violence. Like I said, a lot of shame and embarrassment attached to this. And from our side, the medical system, we are always into diagnosis and investigations and treatment. And so in that flow, this may appear like a social problem, like a personal problem. And they may feel that they're wasting the doctor's time by talking all these stories which are not relevant to her pregnancy per se. That is what women may feel. And yeah, like professions also a lot of times fail to respond to the signs of abuse. So all these could be the barriers from the women's perspective. But there are barriers to professions also to ask violence, to inquire about violence. So when we see what are those, there are several barriers, but the most important one is lack of knowledge or expertise about domestic violence. So there is a fear that if I ask, oh, what if she shares something and I don't know what to do after that? What if I'm not able to help her? So why ask? Why open the Pandora's box? So I won't ask at all, kind of thing. There could be a personal discomfort with the topic. Professional themselves could have had experiences of violence or could have witnessed violence in their own personal life, which may make them uncomfortable with the topic, or lack of expertise, or just thinking it's too complex an issue. And just to do my medical treatment itself is a big thing for me, and I have so many patients waiting, and my OPD is going on, and I still haven't had my lunch. So why will I start this topic which might be too complex for me to handle, and anyway I can't do much help? That is the perspective in a lot of professionals. Like I said previously, dominance of the medical diagnostic and treatment model, limited opportunity. Yes, time constraint is a real reason. It's just not stated as an issue, but it is a real issue when you have so many patients to see in your OPDs. And if the husband is around, then again, the woman may not be comfortable, you may not be comfortable asking the question. of consequences is there in the doctor as well. Because what if it goes into the legal system? Will I be involved? Or what if I can't support the woman? Will I offend her? Will I re-traumatize her? All those fears are there in the professions as well. So I think, yeah, all these put together would be the barriers for why we do not pick up domestic violence in our routine antenatal care. Ma'am? Yeah.
Yeah. So this is about the consequences of domestic violence in women of reproductive age group. So the violence against women has a devastating consequence on women's sexual and reproductive health, not limited to pregnancy alone. And it's most of the studies show that there is genuine diversity across various socio-economic classes, various patterns of violence, not only kind of hitting or beating or something like that. It can be emotional, sexual, financial violence. In India, around 20 to 25% of women reported domestic violence in their past pregnancy. So the impact, the nature of the problem is huge. Now, what is the impact of such problem in reproductive age group women? Intimate partner violence is most often seen in young women, and with the changing socio-demographic configuration, many women who are in, especially in a premarital, short-term or kind of unstable relationships, and maybe these women are dependent upon alcohol and drug abusers. These have higher impact rates. Most often they end up having unplanned or unwanted pregnancies, multiple termination of pregnancies. They suffer from partner controlling over the contraceptive usage, increased depression rates, increased self-harm or suicidal tendencies. And also they have a long-term impact on future marital harmony and their reproductive capacity. Now, during pregnancy, violence can start for the first time, as Dr. Lakshmi mentioned, or escalate during pregnancy. Pregnancy may alter the pattern of assault, while in non-pregnant women, the trauma is different. In pregnant women, most of the violence, the intimate partner violence, the injuries are more likely on the abdomen, resulting in direct impact, leading to abruption or antepartum hemorrhage or even ruptured uterus, or sometimes even premature rupture of membranes. Women who have been found to have 37% higher risk of obstetric complications if the women had interpersonal violence or intimate partner violence during pregnancy. As I have mentioned, it can be directly due to trauma or maybe because of indirect effects which stem from poor antenatal care, drug or alcohol abuse leading to intrauterine growth restriction, increasing hypertensive disorders in pregnancy, intrauterine fetal demise, poor nutrition leading to anemia, poor weight gain, preterm labors, repeated urinary tract infections, and these are all the effects which we see during pregnancy. Now, these consequences are not limited to the mother alone and can extend to the fetus. Babies born are with low birth weight and preterm babies, and increase in perinatal mortality and morbidity or neonatal deaths, and low breastfeeding rates are noted in this population of women. Also, there is increasing depression rate during antepartum and enhanced postpartum depression. And women feel loss of confidence to handle the baby if the women had experienced domestic violence or partner violence during pregnancy. Outside of pregnancy, women who experienced intimate partner violence after deliveries also are more likely to have frequent gynecological consultations with vague lower abdominal pain, dysmenorrhea, dyspareunia, increase in sexually transmitted infections. And these women are at a higher chance of fertility issues. Maybe, partner is controlling the fertility of these women. Some studies show up to 35% or male decides about how many children they want, whether the women should use contraception or shouldn't use contraception. And, if unwanted the pregnancy happens, then she was forced to have a medical termination of pregnancy. So in around 34%, the partner decides about the fertility rather than, woman voice mattering. And also, now, again, it's not mentioned, it's not just simply a physical consequence, it has long-term impact on sexuality, financial consequences, emotional consequences. They may be forced to have abortions, they might be forced to conceive even without her choice, and not allowing using contraceptions, and later demanding MTPs. These are all the consequences, especially seen in young women who are not in a stable relationship and also in a married couple. So the consequences extend to all age group women, whether married or in a relationship. I think with as I have mentioned, with the changing demographic data, socio-demographic configuration, especially the young girls, we should also ask about the violence with the partner when they come for a gynecological visit. So with having known the consequences of the intimate partner violence, how should an obstetrician handle that situation, and how do we minimize the risks to the patient, or in other words, ensure safety of the patient, Dr. Lakshmi?
Yeah. A lot of hesitation from health professionals come because they think, how can I stop violence? I can't go to her house and, do anything. So that is the hesitation. But we have to understand that it's not necessary that you have to go and stop violence, but we can think of various other measures. So let's look at what are the red flags. So when do we have to think that, oh, there may be a possibility of domestic violence in this woman? Like I said, frequent injuries, medically unexplained symptoms. A lot of times, vague aches and pains are put forward by women. Yes, some of them can be symptoms of pregnancy itself, but then when they are unexplained, when the pains keep shifting from one area to another area, and you cannot explain it with any particular reason, and there is a lot of anxiety and apprehension. When you see features of depression, there are self-harm tendencies. Like I was telling earlier, if the woman is seeming to talk to you something which she is not openly talking about, but she has other subtle body language signs, or other ways in which she's communicating to you, appearing tearful, getting startled easily. If one of the main things is, if the husband is in the room, or say mother-in-law, she appears scared, and if that person is not there, then she is much more relaxed. This itself can be a subtle sign for you to just ask, questions like, hey, are you safe at your home? Are you scared of your husband? Now, these could be, opening questions, if at all she wants to talk, and if she gets privacy, if you are able to send the accompanying person a little outside and talk to the woman, these could be questions which will help her open up about what's happening at home. Like Dr. Uma was saying, it's not only physical abuse. There are various other types of abuse, like emotional abuse, economical abuse. A lot of times women are not allowed to work, or I have even seen, well-read, earning very well, those kind of women also, as soon as they get their salary, they have to give the entire salary amount to the father-in-law or the husband, and they don't have the freedom to spend on their own. There is psychological abuse, sexual abuse. So just a sense of control. In a lot of families, we see a sense of control, that anything and everything that the woman does should be under the control of the partner. So we need to be sensitive that it's not only about physical violence. In case we ask, oh, does your husband beat you? And she says no, that's not the end of the story. So what is the intervention that as obstetricians you can do? The WHO has given something called the LIVES approach to deal with violence. So what does LIVES stand for? L is listen, I is inquire, V is validate, E is ensure safety, and S is for support. Help her get some support. So these are the 5 things which can be done as first level intervention whenever, suppose we are the first person to which the woman is talking about abuse. What do we do? Like I said, just listen. A lot of women have nobody to talk to. Even if you just listen closely with empathy and not judging her, not asking questions like, oh, with so much happening, why are you still with that person? How weak are you? Can't you walk out of the marriage? This is the judgment which women fear, right? So without judgment, listening to them closely with empathy, inquiring about their needs and concerns, be curious to understand her story, and ask her what does she need, validate her, saying, yes, I understand, I believe what you're saying. Women have fear that people don't believe what she's saying, because in front of the doctor, the husband or the in-laws might really behave well. They might show that they are really concerned about the woman. So it seems like, oh, she's saying some story which I don't seem to believe, and that'll invalidate her to a large extent. So validate the woman's experience, enhance their safety. So try to understand what is the level of violence. I mean, is it to a level where it is a cause of concern for her safety only? Is it like, her life is at threat? Is it to that extent? In which case, immediately we have to think of just ensuring her safety, support them, and connect with additional services. So this is the approach that can be used by anybody as a first-hand person listening to their story. Yeah.
So Lakshmi, how do you ensure that this woman is safe? You know that this patient has some kind of a violence. So what all would you suggest, or what all should we suggest to ensure that she's safe?
It's important to sort of at least quickly and briefly assess, like I said, what is the level of violence that it is happening. For us to act, how soon should we act? How intensely should we act, kind of thing. But there are certain safety measures which we can always talk to the woman. Ensure confidentiality. Tell her that whatever she's confiding in you will be kept confidential, and at no cost it will be shared to her husband or in-laws family. Ensure privacy. Please document, because there is a high chance that such cases may turn medical legal, and it's very important that you document what the woman has told you. So say, at least write things like history of alleged domestic violence, alleged abuse, etc., and the injuries that you have physically examined. Please document them clearly. Document her obstetric, whatever the status is, much more than what you would do to other cases. Make a safety plan. Okay, so what do we mean by safety plan? Let her have helpline numbers. I will show a list of helpline numbers, but it's always good that each of us have helpline numbers which we put up in our OPDs, so that even if women don't directly talk to us, they can just see the either a pamphlet or just a board where helpline numbers are put up, and ask her to save those numbers under different names. Keep emergency contacts as a speed dial. Ask her to make a safety bag. So a safety bag is in case it comes to an extent where her life is a threat, and if she has to immediately leave her home, then she needs to be ready. Right? So a bag which probably has a pair of clothes, her Aadhaar card or passport, such important documents, driving license, some money or credit card, or whatever her financial for her financial usages, mobile and charger, maybe such things. Let her keep a safety bag at home, so that in case she needs to leave, that second she has to just pick up that bag and leave. Ensure that these cases you do frequent follow-ups. Maybe a nurse can keep calling once a week or once in 2 weeks to ensure how she is doing. A file note that BV should be assessed on follow-up. Even if there's somebody else seeing her on follow-up, just make a note in the file that this has to be assessed again. And only discuss while, like I said, if you feel that the woman is a little uncomfortable, if you see that the OPD is crowded, people can hear what you're talking, etc., then do not talk about it. Please take her to a place where there is complete privacy, and only then ask her about it. Discuss using a code for violence on phone. Like sometimes the woman may call up for help, but then she's not able to actually talk what is happening, right? So in such cases, maybe come up with a code. She'll just tell that code, and it's understood that she is experiencing severe violence. Or she has to just answer yes or no. We ask questions. Oh, is somebody there nearby you? Are you experiencing violence? Is it life-threatening? So for everything, she'll just say yes or no, so that we can try to get immediate help. Discuss which family member or friend can be contacted in case of emergency. Inform about women's support. There are a lot of one-stop centers, women helplines, who will help women in case of crisis. They can even stay there for 1 or 2 days. They'll ensure that legal help is given. So, have first of all, you need to have those numbers in order to give the women. So have that handy. And maybe a poster with local services at your clinic, refer for legal options. And if you find out that partner has substance use, discuss that with him and just check with him if he's willing to take treatment or take some help. Like I said, this is a list of important helplines for women facing domestic violence. This can be shared separately also in the group, or passed on to all the participants who have enrolled in this course, so that you can just keep it handy. Yeah, that's how I will sort of conclude, but we can be open to more discussion.
Yeah. Thank you so much, Dr. Uma ma'am and Dr. Lakshmi ma'am. It was truly a mesmerizing session. Dr. Jayarani Kamraj has joined, and Dr. Jayarani Kamraj, may I request you to give your expert comments?
Kiran.
Thank you.
Okay, go ahead, Jayarani.
Am I audible?
Yes, you are audible, Dr. Jaya.
Yeah. So that's nice, Dr. Uma and Dr. Lakshmi, that you have made the very important, very heart-aching problem in a very sweet and such clear clarity voice for everyone to understand. We know pretty well globally, women goes through violence. 1 in every 3 women go through a violence. And also, all the more it's an interpersonal or the domestic violence or intimate partner violence is the commonest form of violence that women face through. And definitely, pregnancy is not a protection for her at all. Even during pregnancy, she goes through a lot of problem, right from the injury to herself as well as to the offspring, which brings a lot of emotional and psychological and a long-term ill health on the mental health effects on the women and the family as well as the child. All go through a lot of psychological consequences, and you have brought it very nicely. That is how it is very common in the low socioeconomic status, especially up to 30% of the women in the low economic group suffer through this intimate partner violence during pregnancy. And many times we know pretty well it is unreported, mostly because of their difficulty in giving us the lead or, opening to us. And also, it is all our difficulty in not handling it, how to handle it, what next we have to do, how to approach her, how to give her safety. It's many times we gynecologists are also not well aware of the further step that what we have to do for this patient. As we rightly said, we don't want to open the Pandora box and we want to keep it safe. Okay, we'll treat her physically, but we are not looking into her life apart, what next that she'll be going through and how we can protect her, prevent her. It is always a big dilemma and a big question for our practitioners. And definitely, your insights, what you have given, is very much very clear, because many a times it goes unreported because the patient are fearful because of the stigma, because of the social, cultural, and also dependence on the partner, not empowered, economic dependency. All these play a very important role in this type of a intimate partner violence, especially in the lower group. So as you rightly pointed out, that there are always not only the physical impact, it also has a lot of mental, emotional, as well as a lot of controlling behavior which makes them very much restricted in the lifeline, which is very nicely you both have clearly given in your lecture. And also very important that we have to look into the red flag signs, especially when they come to you with repeated injuries, repeated physical harms, or repeated depressions on previous stillbirth or even miscarriages. We should always have a suspicion when you come across when she's not opening up with the presence of the partners or the family members. You should be very careful, and that is very important. The red flag sign is very important.
Please unmute yourself, Dr. Jaya.
Yeah. So that also can happen. So very important that we have to have a screening system which should be there in the antenatal clinic, and any doctor who attends a woman with physical injury should always have a high suspicion that it could be, whether it could be a part of a domestic violence or an intimate partner violence. We should always be very correct. I mean, we should always be suspicious, and we should take all the proper care, as you rightly pointed out, by the WHO lives system. That should be the basic of our approach to any women with an intimate partner violence. So that approach gives her more confidence and gives her more support, and you can give her a better trust and a future care for her. And very interestingly, you have given all the headlines and how we have to give them the support and future care and the safety, and also give them a non-judgmental approach towards a solution for her problem. It is very nice that you have covered everything, and definitely whatever you said to the approach of any women with a domestic violence is really good, and very important that trauma-informed care should be a part of our medical curriculum. In the OBGYN curriculum, we should
Absolutely true.
We should include, because we never have a history in our history of history taking that whether there is any trauma or any other problem with your partner or any abuse you face. We never ask the leading question. If you ask the leading question, almost 90% of the women will answer yes. So that is an approach that we have to change in our history taking as a routine, even if there is not an intimate partner violence case. But if you make it as a routine, means we will come through a lot of higher incidence of prevalence of this among our women in every sector. So I'm very thankful to Uma and Lakshmi for bringing out this very beautifully in a very consolidated, very comprehensive way. I never thought that it would be so much. You can get everything into the nutshell, which is really a good talk. And I thank Sheila Madam and the ICOG team for bringing out such issues also in our ICOG curriculum, which is very important for our fraternity to know, because we think that only lower income group, even the higher income group, well settled, well empowered, even our doctor fraternity, they go through a lot of emotional and controlled behavior aspects of lot of violence from the intimate partner. So it is really a thought-provoking and a mind-blowing session. Thank you so much.
Thank you so much.
I just want to add, Jaya, I just want to add that these women, these survivors should not go back to the home where they have suffered. If they are willing, we must link them to something like Nirmal Chaya we have in Delhi. I was just writing in the chat box that sometimes they may be so insecure that they don't want to go. So we must know our local linkages, where to send them in case of need. Of course, police comes to our rescue if the need be, but we must know our local district protection officers. So they are specified district protection.
See, Government of India in Family Welfare Department, there is a Mukta Center. And all of them, they undergo training for that. The government doctors, they even some have gone to Delhi also. So it is there in district hospital where there are counselors also, where they come and contact, and they have a contact with women and child welfare department.
Yeah.
So they are so oppressed that they can't even express themselves. Yeah.
The one-stop center, Sakhi Center, everything is available everywhere with a very beautiful they have a very good legal persons. They have a support. They have even a economical support, and they have food. They can give them shelter. They can give everything, legal advice, psychological counselors will be there. Everything comes under this one-stop crisis center, which is very beautifully there in all. We should all know about where our one-stop crisis center is available near our clinic. so that if we come across any women, we can immediately ask her. If she's not feeling safe at home, immediately we can send her there. 2-3 days they will give her shelter, counsel her, give her a legal support, give her police protection, and give them even they will shift her to a home where they are very much cared for their future life. So these are all very much common, and government has beautiful laws and regulations related to.
And we must know the
Yeah.
international language also, sign language.
Yeah, thank you
So,
so much, Dr.
yeah.
Jayarani. Great inputs, and it was a pleasure interacting with you during the time of invitation. And I'm so thankful to Dr. Sheila Mane ma'am, Pratik Tambe sir, and Uma Ram ma'am that they have given me this opportunity so I could connect with so many people in India. So now to our next session. It is on the topic is de-escalation and communication skills. And Dr. Jaya, may I request you to introduce our speaker? She is the star speaker, Dr. Ashalesha Bagadia. Please display the slide of ma'am.
Thank you, Dr. Maheshwari. It's my great pleasure and honor to welcome and introduce Dr. Ashlisha Bagdia. Is a perinatal psychiatrist and a psychotherapist with over 24 years of clinical experience, including fellowship in the perinatal psychiatry and women's mental health from University of Toronto. She leads the Chigro Thrive to 5, a perinatal mental health service based on Green Oak Initiative Community Mental Health Center in Bangalore. She is also the director and the co-founder of the PARC, which has been conducting various therapy training programs and mental health programs. We welcome you, Dr.
She will speak on de-escalation and communication
Yeah,
skills. Dr. Ashalesha Bagadia.
Dr. Lakshmi.
Dr. Kiran Mai has joined.
Dr. Lakshmi Shiva.
She is busy with her patient. She
Dr.
joined, but
Kiran Mai,
this is a
Dr.
wrong
Kiran
slide.
Mai, are you there?
Lakshmi is finished now. Yeah.
Yeah,
ma'am,
yeah, it's
Dr. Kiran Mai
Ashlesh.
had joined and then she left again because she was busy with her patient.
Okay.
So
over to you, Dr.
Dr. Ashalesha.
Thank you so much. Thank you so much. This talk is now following the previous one where it is quite difficult circumstances where we have to sensitively handle information, where we have to try and find a right sort of way to get in with our patients. We are worried about violence, we're worried about grief. And again, this session, this talk especially is perhaps I'm telling you things that you already know. So it'll be good to hear from seniors during our interaction also if there's anything that I'm missing. And so this is just again a basic overview on communication skills, either with your patients or the family members. And I'll spend a few minutes at the end just talking about de-escalating when temperatures are very high, and people are quite upset, and how do you work towards managing that situation. So when we think of communication, I just want to think of our words which can help as a way to remember. Whenever you are trying to communicate, especially with someone where there is, say, a mental health issue, or you need to communicate bad news, or you need to counsel them, it's important to think and recognize what the barriers might be between you and this person. In one of the questions today, someone was saying, that patients can be quite illiterate. They may not understand what is an encephaly. So the barrier might be that, their literacy is poor, their knowledge is poor. So there may be many barriers that come in the way of communicating. There may be patient-related barriers. There may be obstetrician-related barriers. You may have been in an environment where communication may be hampered. So recognizing barriers is important. And then what you want to do is, once you have the idea of the barriers in the back of your mind, you want to make sure you start with reassuring, open-ended questions. You also want to not narrow down very quickly in the beginning itself. So the open-ended questions are more driven at reassuring rather than eliciting information. It's kind of directing a little bit of direction towards what kind of information you want. And when they give you a response, then reframing their response. So often just summarizing, reframing it to make sure that, have I got this right? Is this what's going on? It also helps them to see that you're listening. retrace and exploring. So it's about giving the information, listening, going back and exploring further. And the most important thing really is also in how you respond to the person you're communicating with. And often what we are doing, and this is not just in our patient doctor interaction, but generally when we're talking to someone, what we are more likely to be doing is while they are telling us something, we're already moving on to the next step of what we are going to tell them in return rather than listening to them. So, first you want to listen and then form your response, and then think of, okay, how am I going to solve the problem they're putting in front of me? And of course, the main thing for our sessions that we want to look at, how do you refer on? How do you monitor? How do you move on to the next step? So communication includes all of these things, and it's important to keep these things in mind. So in terms of recognizing the barriers, I mentioned literacy one, but a common one is that they may not even be very forthcoming with their problem. There may be fear of stigma. There may be negative perceptions. If they tell you that they're feeling sad or feeling low, then you may perceive them as a unfit mother. They may fear that their baby might be taken away by so-called well-meaning in-laws, or they may face a lot of judgment from the family if they share what is going on in their mind. They may also be fearful that they are the only ones who are presenting like this. That they may not be aware that if they have symptoms of, say, anxiety, depression, that this is something that is common, especially in antenatal. There is still a little bit of rising awareness of, say, postnatal depression and low mood. But antenatally, during pregnancy, when someone has low mood, that seems to create a lot of internal stigma, avoidance, not wanting to share. And another one that we are seeing now more often is in perimenopause. There is an understanding that there are mood swings, but when they are going through, say, a depressive episode or very anxious, it is not something that they recognize is it's normal for others to feel. So their stigma of sharing may be a problem. So even if they have shared, their reluctance to engage is another barrier. They may want to avoid, and a very common thing in India is that even if they're telling you that they're sad, you may give them a very nice comprehensive plan, but they want to avoid dealing with it. And there is, like an internal sort of thing that if I talk more, then it will get bigger. If I say it out loud, then it will never go away. Or people will misunderstand me. There'll be a retaliation from the family. And of course, one of the biggest barriers is, especially if you're seeing someone after getting married, they may have had a mental illness or some kind of history before they got married, which has not been revealed to the marital family. And so, this undisclosed past history, very common. Even like someone mentioned, violence and abuse is common in all socioeconomic strata. The same way, past history of mental illness, which is not revealed to the husband, or it could be the other way, the husband may not have revealed to the wife. This can happen in any socioeconomic level. And another barrier in communicating or poor communication can be conflict or violence in the family relationships. So these are some of the barriers. I'm sure you may be aware of even more, but recognizing and especially what is a unique barrier that your patient is facing might be very important before you sort of enter the communication space with them. So when you start off by talking to them, it's important that you sort of start by normalizing, setting a little bit of context. No, don't just jump into anything. Now I know we've said general communication, but we're obviously talking about communicating when you're concerned about, say, a mental health issue, you're concerned about domestic violence, when you have to sort of elicit information that may be quite sensitive. So you really want to normalize, set the background. And again, I'm quite confident that most of you must already be doing this. This is just sort of reminders for us to, reset our mind and see if there's anything different that comes up. So some of the things like statements like, we can discuss anything here. It's confidential, and I'd like to help in whichever way I can. So tell me, how have you been feeling lately? So an open-ended question like that is better than saying, are you feeling sad? Right? How are you coping? Especially if they tell you something like, oh my God, my older child is 4 years old and the there is no nanny, she stopped coming, my mother was supposed to come but she wasn't. So they'll tell you a whole list of problems, and the urge is sort of either to give them a solution or to sort of say don't rely on others, or to say don't worry. What you want to do is hear more about how it's affecting them. So your question is more on how are you coping? This sounds like a lot. How are you doing emotionally? And another common way of normalizing, of course, is that, this whole perinatal phase, hormonal difficulties can be quite difficult. It's very common for women to feel anxious, feel like they're overwhelmed, feel like everything is sort of, coming all at once. And it's okay that you may not feel like sharing those feelings. So even not being able to talk can be normalized. So starting off by normalizing a little bit before going and digging and exploring is very important. Another crucial thing I think Dr. Lakshmi also mentioned in her talk is that to start with open-ended questions is very important. So just to kind of give you an idea of differentiating between the two, uh, instead of asking, are you feeling sad all the time? Because you're narrowing it down, you're sort of only giving them a yes or no answer, is to keep it open. How are you feeling? What has your mood been like? So you want to know about the mood in general. What is your sleep been like? Rather than asking them, are you not sleeping well? Right? And open-ended questions can be something like, tell me more. What kind of support do you have at home? And definitely, when you want to ask something like suicide, and I'll go into asking about suicide, that you do need to ask direct questions, but you need to sort of lead up to it. So instead of asking, how is there no one to help you at home? Your open-ended question would be, what kind of support do you have at home? How has it left you feeling? So you want to build a context before you go into direct questions. After you've sort of done this initial bit and reassured them, you really want to reframe and summarize. You then, once you got a ballpark, okay, there is a lot of anxiety, and they have a supportive husband, but in-laws are visiting. So you have a little bit of context, you have a little bit of what the barriers are, what the difficulties is. Then you start reframing and summarize. So it looks like, your husband is quite understanding when it's just the two of you, but because your in-laws are in town, you're having a difficult time. How long are they likely to stay? Then you can be very direct and you can sort of say, oh, they're going to stay for another month. So, what kind of anxiety do you feel? Do you get panic attacks? You can even go through questionnaire at this time. And what you really want to do is come across that you are asking questions to want to understand rather than interrogate them for like a checklist. So when you're administering questionnaires, that's another thing to remember, that you don't want to sound like you're just going through a checklist. Even you can reframe the questions a little bit, add a little bit more empathy, because ultimately you really want to understand what's happening to them. And the most crucial part, especially when you're dealing with mental health issues, is to encourage them to solve the problem rather than you give solutions. Because the commonest thing will happen is that they, of course, may or may not even try what you suggested, but they are more likely to blame you. It didn't work, nothing is working. And when someone says it didn't work, more likely the possibility is that they haven't tried it, and they'll often come, take advice, go and do nothing different, and then come back and say nothing has changed. So you want to really be careful, and this may not be like it's a bad thing that they're doing. It's just that maybe the anxiety and depression has led them to be in that helpless state, so they're not able to do any of that. So what you want to do by encouraging them to say, okay, so what are you going to do when your mother-in-law is here for a month? How are you going to cope? And so they then have to start thinking, rather than you saying, okay, go visit your mom, call your friend over. So you are then giving solutions which may work actually. But what happens is then they stop thinking. So you really want to encourage problem solving than giving solutions immediately. And when you are sort of thinking, okay, how do I refer this person on? Looks like she needs, to talk to someone. Like someone mentioned earlier, that maybe now she needs professional help, and you can be the person they can come and tell if it went well. So you're not removing yourself from the scene as much as you're sort of gently nudging them towards more professional help. And the referral needs to be customized as much as possible, of course, with the lack of resources that we have around here. But if they're sort of sounding like they're keen to see a psychiatrist, they're okay, they have no problems, they've seen someone before, then it's all right to refer to a psychiatrist. But often you might want to go through a counselor or a psychologist first, and then, build it up to a psychiatrist. So customize the referral as much as possible rather than giving everyone the same sort of referral option. Now, just in terms of communication around suicide, and if you're worried about, there is a risk of this, then again, you want to set the scene a little bit. Don't jump right into the question, but you want to sort of say, okay, it sounds like you've gone through a lot. Have you felt that this is perhaps too much? Did you feel like completely overwhelmed by all the things that have happened that you didn't see any way out? So you try and find different ways of sort of asking it. Again, remember, you're not beating around the bush. You're just asking, has this been too much for you? So when you are sort of hesitating a lot and saying, sometimes people don't feel like living. And so when you're hesitating and sort of being a little tentative, they might also start feeling reluctant. So it's all right to set the scene, but when you're asking, be quite clear in what you're asking and be precise. So you can say something like, some women report thoughts of suicide when they feel very helpless, when they feel like they have no way out. Have you had any such thoughts? And a good question I like asking is, what's the closest you come to trying anything? Because if you ask them, have you tried any suicidal attempts? They'll say no, and you're done. Okay, everything's fine. But many times they might have come close to, they might have started looking for ropes, they might have looked for pesticides. So you really want to know what's the closest they've come to, which gives you a mindset. One is that they're very close to the edge. Two is there are some protective factors that pulled them back. They might say, yeah, I was looking for ropes and I just saw my son sleeping. He looks so innocent. How could I do this to him? So, there are protective factors that might pull them back. So asking them what's the closest they've come to trying anything is very helpful. And another crucial question to ask is that, if you do end up feeling like that or feeling very close to the edge, is there anyone you could reach out for help? And getting some kind of a commitment towards this. So, if it's your husband, how are you going to reach him? Does he know that you're going to reach out? Does he know what to do if you reach out to him? Can you both have a discussion on where should he take you? So you really want to make sure that you're not just asking about suicidality now, especially if they're saying it's okay and you determine that the risk is low. Okay, if it changes dynamically, especially when someone is anxious or depressed, and if they're pregnant and things are constantly changing, then their suicide risk might also change. So today they might say, I'm fine. Tomorrow, when they're not in your presence or they're not going to see you for another month, in the middle of that, they might suddenly feel suicidal. So you want to give them, okay, who are you going to call in that time, right? So this was just about communication in general. And again, we've sort of covered specific communication skills. But remember that when you are sharing bad news or sharing information that they don't like to hear, there is likelihood of them escalating. And so when you talk about de-escalation, we are really looking at, someone who's become heightened, has developed heightened emotional state. And what you want to do in that moment. So the purpose of de-escalation is to reduce the intensity of the situation sufficiently so that you can focus on the problem. In that moment of de-escalation, you're not solving the problem. So in our previous example today, for the case that Dr. Varalakshmi was presenting, where it said that the husband wanted to know, was very angry, wanted to know what's happening right now. And of course, you want to give them the answers. You want to problem solve with them and say, no, you know what, the sugar levels were very high. We couldn't have anticipated this. So you want to have that conversation. But in those few moments, before you have the conversation, you need to de-escalate the situation. So the purpose of de-escalation is to reduce the intensity of the situation sufficiently to then focus on the crisis. Or you can even say, okay, can we talk this afternoon? And in that moment of de-escalation, so de-escalation is a brief thing, activity that you're doing. It is not solving major crisis problems later on. In that moment, you first need to establish safety for yourself and then for the client. So both the safety needs to be established, right? And by safety, I don't mean that only risk of client hitting you or the patient hitting you, but it's also about, are they going to be safe? If they start shouting, like I mentioned earlier, if your nurse or junior thinks that you are at risk, they might then act out and be, cause harm to the patient. So it's important that you establish safety for yourself and for them. And what you essentially want to do in those few moments is transfer your sense of calm and genuine interest in what do they want. So you want to have respectful, clear limit setting. So especially if they're shouting loudly and it's like, a ward where other patients are there, you really want to sort of say, this looks like you're really upset. Shall we go to a quiet place where we can talk? So you want to encourage them to move to a quieter place, or encouraging them to sort of say, you can't talk this loudly, in as respectfully as possible. So you can move them to a quieter area where the problem can be resolved. And how you do this de-escalation has to be a bit verbally and with non-verbal cues. So if you're standing like this, huffed up, and said, okay, you need to calm down, only then I'll talk to you, even if you appear very gentle in your tone, it's not giving a very welcoming, calming vibe. So you want to have neutral sort of body posture. And no matter how fast your heart is beating and you're getting scared, you want to have a sort of leaned in, interested sort of body posture. You want to maintain eye contact with them. You want to be looking at them when you're addressing them. So both verbal and non-verbal cues are very important. And what you are really aiming to do in the de-escalation is build rapid rapport and a sense of connection with the agitated person. So you're not there to take a whole, and this is something that I tell, if I'm teaching my psychology students or therapy students, is you're not there to conduct a session. You're not there to do any big sermon, gyan. You don't want to solve their life problems. This is just rapid rapport, and immediately right now we build a connection. What can we do to solve this? Reduce the intensity of the situation. If you get a chance to do this is not always possible in the immediate sort of setting, but this is something you can think about, and make sure that rooms are established where there are safe rooms where there are not too many things to access for them to pick up and throw, especially if you're taking them to a safe room. If you're going to talk to someone who's agitated and have removed them from a public space, make sure that there are other people around you and with you when you're talking to them in a quiet room. And also always remember to sit next to the door when you are talking to someone who has a potential to become agitated again, so that you can leave the room. If you are in between them and they are between you and the door, then that's potentially a difficult situation. So sit towards the door so you can get out easily and get help. You also don't want to be in their face. They might be in your face, but you also maintain a safe distance. And you don't want to have a stance that, okay, I'm going to leave any minute if you become angry. But you also don't want to be in their space. So you are looking at them, watching them, engaging them, but also maintaining a safe distance. Um, Another sort of common thing that comes up more in, say, a psychiatric setting or a psychology setting is, do you have a desk in between you and them? Do you sit sideways? Do you sit across them? Now, these things are really depending on your clinical setup, what you have access to. If you're in an institution, you don't have the luxury to think of all these things. So if you can think of just one or two things, it's important, especially your access to exit. Definitely removing things that can be used to attack or break. Sometimes in some places, what they've started to do is to have a quiet room where if a patient has been agitated or a family member, you can take them away to a safe place and to sit down. And that room is a designated kind of quiet room where you break bad news, where you sort of have difficult conversations, where you really don't have things that can be pulled and broken and, sort of used by an agitated patient. And so instead of breakable things, you add softer things, pillows, throws, things like that. So even if they sort of hold on to it and they use that to manage their frustration, it's not going to cause much damage. So, of course, this is something that I don't think we need to tell you. So, just in terms of the emotional signs that you obviously might see if someone is getting upset, is if they're crying, but they're sort of crying non-stop and it's rising to a crescendo, shouting, of course. They might also be panicking. They might like, I don't know what to do. I don't know what to do. They might sort of be a little all over the place. And that may be a situation also that you may have to de-escalate quite quickly. They may appear quite confused and anxious. Tomorrow, we're going to talk a little bit about psychosis and psychiatric emergencies. But this is just, in that moment for a few brief seconds, how can you de escalate? So, also, they might be, I'm talking a little bit about someone who's agitated and in your face and angry, but sometimes they can also be sort of passively mute and refusing and or maybe just so sort of zoned out because they're traumatized. So in these situations, you may need to sort of get a response from them saying, "Are you okay?" Because if they're so dissociated or sort of switched off, you want them to be upregulated a little bit so that you can engage in the problem solving conversation. And of course, if they're pacing, fidgeting, and these are some of the signs that you can train your team to pick up, because they can pick this up even before you have gone up to them. And this picking up these emotional signs can be helpful to de-escalate the situation before it reaches a point of no return. Before you know it, there's a mob there. So it's important that they're picked up a little early and you're addressing them a little bit early so that you don't have a crisis on your hands. And of course, watching out for physical signs, like they might be just rocking and swaying. They might start clenching their fists and tightening their neck muscles. They might pace quite rapidly. They might look like they're breathing rapidly. And their speech might be very rapid as well. So they're sort of not necessarily manic, which is again another condition that you we'll talk about tomorrow. But they might just be, trying to ask too many questions in a hurry because they're anxious, or they've suddenly gone quiet. So, keeping an eye out, especially, for example, the case that we heard earlier, where things are going wrong and it's going on for a while, right? So you want make sure that the team is kind of keeping an eye. Okay, this is a at-risk family. The baby looks like it's not going to survive. So let's watch out and see for any signs of escalated emotions that we may have to sort of de-escalate and manage before it reaches a very difficult stage. So this is a very useful thing to keep in mind, when someone is at this high end of very angry and very sort of agitated, or if they're completely dissociated, crying profusely, you're not going to get anywhere with them if they're either end of this. So your efforts in de-escalation is really to bring them to the middle, orange, yellow, or green, where some conversation can be had. And that is all you have to do. And I've given some tips, but I'm sure there are many ways in which you are quite skilled in making that happen. But remember this, that unless they're in those middle phase, they're not going to be able to solve anything with you. So engaging with someone in solving the problem with someone who's very angry is a little futile unless you help them to calm down a little bit. Before you jump in, always pause, even if for the briefest of second, and take a deep breath. Because often you're sort of running from somewhere and running right into something. So that is a crucial thing to do, and you notice what's happening, and you can ask them to pause, especially they're saying so many things. I want answers right now. So you might say, yes, I do want to address your answers. Can you just slow down a bit so I can sort of plan as to how we are going to go about this? So you get them to slow down, you respect their personal space, and you ask them to respect yours. And you want to maintain kind of a neutral eye contact, not like a glaring, I'm going to pin you down. You don't want that I've got my eyes on you kind of feeling, so that they don't feel threatened. But you want to sort of match a little bit of their expression. If they're looking angry, you might sort of look a little concerned. If you are going to have this, come on, everything is fine, I'm okay. So you want to transfer your sense of calm, but you don't want to look like nothing is wrong. So mirroring actually is a very useful technique that you'll see a mother's new mothers do all the time, right? Mothers are always mirroring the baby's facial expression, and that mirroring actually really helps to regulate the baby as well. The same way, when someone is telling you something horrific or scary, if you sort of show concern that is matching their emotions, that really helps to make them realize that you are listening and you are having an effect, like it's having an effect on you. You're not just listening like one wall, a neutral doctor who doesn't understand anything. But you also have to make sure that your mirroring is not even more dysregulated than theirs. So you show concern, you regulate your concern, and then continue engaging. And you also want to lower your voice and keep your tone even. You don't want to go up and down, sort of, what is wrong with you? Why can't you understand what I'm saying? But and I know this is hard. So if you keep sort of fluctuating, that's going to further dysregulate them. And if they are sort of able to say something in a coherent manner without throwing accusations, without being angry, then you've got them to that middle stage of the emotions meter, and then you can start having a conversation. But if they're still agitated, go back to the top and repeat the same thing. So you need to get them to that point where you can start engaging with them. And then when you feel they're in that yellow green zone, then you can start addressing the issue, which sometimes might be giving them some education, answering their questions, clarifying some things. And then you may reach a point of negotiation. Okay, we do need to get the baby off the ventilator. And so you then start discussing what may need to happen, how much time are you able to give them, what, especially if someone needs to be discharged, moved from the bed and things like that. And always the next step, especially after an agitated patient, it's all right to compromise a little. It doesn't mean that you have failed, that you have given in and the patient won. These are people who have experienced something difficult. The reason why you may need to do some sensitive communication is because they're going through something. So always have a little bit of compromise in you if you can, especially if it is something that is in your hands. Of course, if your boss or someone else has made a decision and it's not in your hands, then you can't do much about it. But there's always room to compromise on both ends. And you can sort of do that bargaining and say, well, I'm meeting you halfway. Can you meet me halfway? And can we figure out the next steps? Another crucial thing when you're de-escalating the situation is all right to say, let's set another time to talk about it. Maybe, you haven't had anything to eat all day. Is that something you'd like to do? Let's take a break and come back. So deciding to talk about it later makes them also feel reassured that you're not just brushing aside, you're actually dedicating a time and you're going to spend time with them to understand what's happening. So their need for escalating, making them feel heard will go down.
Yeah, thank you
Of
so
course,
much, ma'am.
yeah, so this is the last thing. Again, very similar to what I said earlier. In all of these situations, taking care of yourself is very, very important. We'll again talk about this more next tomorrow, but I will stop there.
Yeah, thank you so much, ma'am, for a brilliant talk. And Dr. Kiranmay Devnani has joined. I welcome you, ma'am. Ma'am, I'm just introducing her again. Ma'am is the head of the department of GMC, Vanapathy, and she was also the chairperson of FOGSI No to Violence Against Women Committee 2023-25. Ma'am, I request you to give your expert comments on her talk. Yeah, thank you so much.
Yeah, a wonderful talk. I think the whole 3 days certification course will act as a sensitization, much needed sensitization workshop to all the OB-GYN. Of course, I was just yesterday, one of my colleagues had sent a NEJM paper on the causes of death, maternal mortality in the US for a 6-year period. So hypertension, hemorrhage, infection apart, equal number of deaths were caused by, one was drug overuse, second was interpersonal violence, and then suicide and homicides. So 2018 deaths were caused by these factors, whereas another 2000 deaths were caused by our usual, causes of death. So much burden of mental health issues and violence is there, and we are the point of care contact. And the survivor-centered approach is the most important. We all need to be trained, sensitized, and know how to do the referral practices. And Dr. Ashlesha has very, very wonderfully elaborated on this. Thank you for making me a part. Thank you, Dr.
Thank you. Thank you so much. Dr. Jayarani Kamraj, would you like to add something?
Yeah, that is as it is the escalation. De-escalation is very important in a communication, and I think she has mentioned it very nicely from the psychiatrist point of view, which we all should take it up in our day-to-day, even a communication related to the spouse, related to the partners and everything. It is very important that how we have to communicate, which is really mind-blowing. Thank you for that lovely insights about that, which we all need. And Madam Sheila, Madam, it's really amazing the 2 days, your all 3 days workshop regarding this. It's very much needed and very important. We have talked more obstetrics and gynec. We need some such things more into our clinical forum, Madam. Thank you so much for your visionary things. Thank you, ma'am.
Yeah, Madam Sheila, ma'am, would you like to?
Yeah.
Say something.
I think all the sessions are excellent. The discussion and obstetrician as well as the psychiatrist together, bringing out all the simple points, but and you people have such simple slides, but it gives you so much of message. Okay,
Yeah.
so it's very, very informative, and I think it will be really helpful. And I hope that now we have generated interest, Shashi.
Yes, yes,
Yeah.
yes,
So,
yes. So our next,
it-
yes, yes, ma'am.
yeah, I think we should proceed now. I think
Yeah.
we have a panel, and
Yes, yes. Our next speaker has already been introduced in her earlier talks. She will speak, Dr. Lakshmi Shiva. Ma'am,
Yes, ma'am. Yes.
she'll speak on substance abuse.
Yeah. Can I share my slides?
So yeah, the platform is yours now.
Yeah. Is it visible?
Yes, please put on slideshow. Yeah, absolutely right.
Okay. Okay. Thanks for calling me again. So
Thank you.
this is again, like just now, ma'am was talking about what are the other causes of mortality under which interpersonal violence came, substance abuse came. So we are trying to delve into one more, hidden demon in terms of mortality and morbidity in the perinatal period. Just to introduce, again, pregnancy, some people, generally believe that pregnancy is the right time for a woman to lead a healthy life. A lot of times we see families saying, maybe she should just become pregnant and then she'll quit all substances. Maybe she'll just quit tobacco. It is true that women tend to sort of, pay more attention because now it's just not them. There's also the fetus, the child, which is going to be affected. So they do tend to be a little more careful. But that doesn't mean that everybody becomes abstinent. Some women continue to use substances. Again, substance use it's not a simple thing at all. It has complex interaction of one's own psychological influences, personality traits, environmental factors. So it's a complex connection of all these things. So there is a possibility that women may continue to use substances. From the perspective of India, what are the commonly used substances? Tobacco, alcohol, and cannabis. Opioids is also rare in India, but I'm just like making a passing mark on that. According to the NFHS 5, the prevalence of tobacco and alcohol use in pregnancy in India was 2.5% and 0.4%, respectively. So, what are the risk factors which you need to sort of keep in mind while assessing a woman, or if you suspect substance use, then what are the things that should make you think of it? Past history of substance use. So, if any woman says that she has used substance in the past, then yes, it should raise questions. If it's an unplanned pregnancy, if the woman is coming from a lower socioeconomic status with lower education, unemployment, younger age, cultural factors, such as, there are certain cultural factors like giving alcohol during the postpartum period. So, just find out if such things exist. Physical and mental health conditions which might coexist, which could exacerbate or precipitate substance use. Past experiences of childhood trauma, sexual trauma, these again become important. Exposure to violence. We spoke how violence and substance use are quite interrelated. Women having substance use are more likely to experience violence, and it's the other way also. Women who experience violence are more likely to go seek substances. So it's a very important thing. What is the availability of substances to this woman? Is it like the partner drinks? Do they have alcohol available at home? Such factors. And how much is the awareness regarding the harmful effects of substances on her, on the fetus, during pregnancy, during postpartum breastfeeding, etc. So all these things can be considered as risk factors. Impact, of course, I'm not going in detail. All of you will definitely know what is the impact of substance use in the perinatal period. There is increased maternal morbidity, adverse pregnancy outcomes, adverse neonatal outcomes in terms of preterm birth, low birth weight, admission to an ICU, stillbirth, etc. And there are long-term outcomes also in the infant in terms of neurodevelopment, learning, behavior, even at age 3, age 5, age 10. There have been studies to show that those children who were exposed in utero to substances have neurodevelopmental deficits. Okay, I'm making it quick, so I'm directly going to what can you do as a primary care physician to think about substance use in a woman. So screening, brief intervention, and referral to treatment. These are the things that you can do as obstetricians. So we sort of try go into each one of them and see when do you use these things. Screening, how do you do screening? Again, it's a very simple thing. Don't think of using questionnaires, screening instruments, etc. Those will be very difficult in your routine practice in clinic. Simple questions like, in the past year, how many times have you drunk more than 2 alcoholic drinks per day? Have you used tobacco of any form in the last 1 year? If so, how much, what form, etc. Those things. Have you taken any prescription drugs for non-medical reasons? Have you taken any other substance in the last 1 year? So it could be like simple questions, open-ended. Do you use substances? If so, how much do you use, etc. Urine toxicology as a routine practice may not be essential. It can be used in combination with your screening, but it's not like every woman who enters the clinic should undergo urine toxicology test. What do we mean by brief intervention? Brief intervention is, one, you have to talk to the woman about what are the effects of substance use on the mother or on the fetus and the infant. Provide counseling to all pregnant women as a part of routine antenatal services about the effects of substances. If somebody is trying to talk about substances, creating a non-judgmental and safe environment. Now, this is very important, like how we spoke about violence, where women are very apprehensive to talk, especially in our culture. It's not in Western countries where many people use substances, right? Here, relatively, the women who use substances during pregnancy and all is still less. And therefore, if somebody opens up, somebody says, I do smoke cannabis occasionally, and immediately you'll be like, what? How could you do this? And this is so bad. And don't you have sense that it will affect the fetus, etc. If that is the response, again, nobody would want to open up. So creating a non-judgmental and safe environment is important. The 5 A's. So brief intervention is the 5 A's: ask, advise, assess, assist, and arrange. Arrange for referral services. So ask about substance use, advise them about what are the ill effects on her and on the fetus, assess how much is the substance use, assist her in terms of making a decision or conveying her, or even talking about how would she want to take this further, and arrange for referral services. Make sure that you have frequent follow-ups, much more frequently than what you want to do for just the obstetric care. So categorize the women into low risk, moderate risk, and high risk. When do you say low risk? Low risk is when somebody has never used substances in the past. So there's no past history of substance use, or there is minimal substance use, but it has ceased. Either just before pregnancy she stopped, or as soon as she got to know that she's pregnant, she stopped. So that will come under low risk. What do you need to do for low risk? Just brief advice, reinforcing that, yes, it's good that you stopped and never do it again. Sort of an advice is sufficient for low risk. Moderate risk. When do you say it is moderate risk? When there's a past history of substance use disorder, when she was using some substance quite frequently. If there has been a recent treatment for substance use, say She says 3 months before I had taken treatment for abstinence of alcohol, or I used nicotine replacement, etc., then yes, she will fall under moderate risk. Or there is occasional use in pregnancy also. She says just once in 2 months I have smoked one cigarette, then it will be moderate risk. For moderate risk, again, brief interventions may suffice. Whatever I spoke in the last slide about brief interventions. If the woman falls under high risk, what do you mean by high risk? There is continued substance use during pregnancy, and currently she's meeting the criteria for a substance use disorder. You might not know the criteria for substance use disorder and all that, which is okay. But if there is continued use, currently also she says, yes, I'm using, then she will fall under high risk. And then it's necessary that you have to refer to higher centers for her treatment. Even in moderate risk, you might want to refer, but maybe there is a little bit of leeway time there. Whereas if it is high risk, then it has to be done on priority. So management of substance use should be multidisciplinary. The obstetric management should be there, psychosocial management, pharmacological management. If there is active use of substances, we might want to do, the withdrawal treatment, etc. for if she's stopping suddenly. Recovery-oriented services need to be there. So let's just look briefly into each of the substances. Tobacco use. A lot of times, tobacco is just not cigarette. You might ask the woman, do you smoke cigarettes? And she says no. And you move forward because there are a lot of other forms of tobacco, especially these days, vaping and all is quite high and considered to be cool. They think it's not as bad as cigarette. They think vape is okay, not as bad as cigarette, not as bad as chewable tobacco, etc. So it's important that you get to ask all forms of tobacco use. Ask for secondhand smoke exposure. So again, this is extremely important. The woman might not smoke herself, but then she might be in a house where her husband is a chain smoker or her father smokes. So please check for home or office exposure to secondhand smoke. Refer her to tobacco quit lines. Nicotine replacement we do give in pregnancy, but gums and lozenges, which are short acting, that is more preferable. We don't usually use a nicotine patch because a nicotine patch is through the day. Nicotine patch is what you apply on the skin and it's there from morning till night, except for the time that she is sleeping, it'll be there. So we don't prefer patch. Gums and lozenges are preferred. Be aware that she might stop in pregnancy, but then immediately there may be a relapse in postpartum. So while you're talking about effects, please talk about the effects during lactation as well. And check for substance use in the spouse and take steps for advising the spouse also for smoking cessation. When you come to alcohol, the dictum is no safe level of alcohol during pregnancy. So some women may say, I'm just drinking 30 ml once in a month, no problem. No, tell them that no safe level of alcohol is, identified. General actions, again, inform, educate, screen all women of childbearing age for alcohol use. There are some efficient laboratory markers to detect excessive alcohol consumption. So if you get a doubt that the woman is underreporting or she is lying, etc., you might want to use these. These are some of the liver function tests that you can take. The carbohydrate deficient transferrin is quite a specific marker for alcohol consumption, and it can be done in suspected women. Again, what do you do? Like I said earlier, if it is low risk, then you just have to I already told you what is low risk, what is moderate risk, and what is high risk. So low risk, that she's either not used or used very little and she's stopped herself. Moderate risk is when she's low level of alcohol use during pregnancy and early on it is stopped. High risk is even when there is current use of high doses of alcohol, according to self-reports. Or if there is a past history of fetal alcohol syndrome in her previous pregnancy, if that had happened, then she will fall into high risk even in the current pregnancy. So for low risk women, what do? you briefly advise, reinforce. For moderate risk, follow the brief intervention, arrange for psychosocial support, maybe put her in touch with a psychologist or a counselor, arrange for frequent follow-up visits. Breastfeeding is generally not recommended. High-risk women, you have to refer to addiction services and treat the alcohol withdrawal. Here also, breastfeeding is generally not recommended. Cannabis, these days, in fact, more than tobacco, alcohol, cannabis is very common. You might be surprised with the rates that we see in young people. They don't drink alcohol now. They consider it to be like uncool, getting high, falling on the road, and they don't want to do that. But cannabis is extremely common. So they consider it to be a recreational drug. Some women think it is safe for nausea, vomiting, even good for mental health. There are, they'll pick out papers saying how cannabis is useful and we should take cannabis, etc. So all those notions have to be kept in mind. It can cause higher rates of postpartum depression. There is no established pharmacological treatment that we do for cannabis disorder, but non-pharmacologically, we have to manage the cannabis use in pregnancy. Opioid, just to state, I'm saying that a lot of opioid cases, if they are, if they are meeting the criteria for a substance use disorder, we have to give opioid maintenance therapy with methadone or buprenorphine. Why I'm saying this is at times they may be advised otherwise by the obstetrician saying, okay, don't take anything, it's not safe. And then what we are risking is she will continue to use substances rather than using the maintenance therapy. So kindly get in touch with a psychiatrist who has advised and get to know why it has been advised. If the delivery has happened and the neonate is diagnosed with opioid withdrawal syndrome, then supportive care, low stimulation environment, swaddling, skin-to-skin contact, frequent feeds, along with breastfeeding when appropriate. All these have to be done. One slide on breastfeeding. Tobacco is not an absolute contraindication. You have to strongly encourage smoking cessation aids and avoidance of secondhand smoke. In alcohol use, it is discouraged. Again, some guidelines say totally avoid, whereas some guidelines say if it's occasional use, then avoid breastfeeding for 2 hours after one drink and avoid breastfeeding for 4 to 8 hours if it is more than one drink. Cannabis, there is no safe level established, encouraged abstinence. Opioids, breastfeeding is encouraged unless particularly contraindicated because the benefits outweigh the risks in the opioid exposed infants. What is the role of obstetrician? Just reiterating whatever I've already said, sensitive screening, non-judgmental approach. Mention that you're asking because these are routine questions. You just say that we ask this to everybody so that she doesn't feel that, why are you asking me, kind of thing. So even in interpersonal violence as well as substance use, just say that these are routine questions we ask everybody, and that's why I'm asking, do you use substances? Discuss the effects on pregnancy, fetus, breastfeeding, and be very aware that a lot of times her actual problem could be anxiety, it could be depression, it could be ADHD, there could be some other underlying psychiatric problem, and they're just covering that up with substance use. So just saying, okay, don't use substances is not enough. We'll have to sort of understand why she's resorting to use substances. Offer referral services all the time. Thank you.
Thank you so much, Dr. Lakshmi Shiva. Dr. Kiran, may I request you to give a two-liner comment on this as we are running short of time? Yes.
Yeah, sure. I work in a medical college in Telangana, and right now it's a periphery district kind of thing. So the use of toddy as substance abuse is quite common, is what we have observed, and there is a cultural factor to it that many believe that this toddy helps in cooling effect, and it improves the it relaxes anti-anxiety kind of thing. And also maybe there is an adulteration or a mix with diazepams, but there is a lot of toddy withdrawal and including epilepsy that we are seeing. That is one thing. The second thing is, of course, Dr. Lakshmi has covered extensively and beautifully the whole, all the aspects of substance abuse. There are interactions and interrelation between violence against women, substance abuse, mental health issues, and malnutrition, chronic malnutrition. So everything is so much interrelated. So we need to focus on this. We do screen for substance abuse as a routine questionnaire. We say that we ask this for everybody, of course. So that helps. Like violence, we have to screen very sensitively for substance abuse also. Thank you so much.
Thank you so much. Now we are moving to the next session. It is a panel discussion by Dr. Parul Tank and Dr. Vera Lakshmi. Please display their slides. Dr. Parul and Dr. Vera Lakshmi, please introduce yourself and your panelists also.
We have to get on. We are running a little late. Okay.
Yeah, that's why.
Yeah.
Please put it on slideshow.
Give me a minute. Huh?
Yeah. In the meantime, Dr. Vera Lakshmi and Dr. Parul, you can introduce yourself.
I've been already introduced. So I'm from Hyderabad. And Dr. Parul?
I'm a consultant psychiatrist. I'm working in Mumbai. And
Okay. Yeah. Welcome to
Thank you, Dr.
our academic program.
Thank you.
So can you?
No.
1 second.
The slide was showing earlier. You just make it on slideshow, not this one.
Maybe going to PowerPoints.
Yes. Sorry.
Welcome to the panelists as well as the participants in the meantime.
Till Madam is sharing slide, the panelists can introduce themselves. Dr. Shakuntala Kumar, I can introduce her. She's from Delhi, that's why. She's one of the very senior members of Delhi Gynae Forum and a great academician.
Can you see the slides now?
And
yes.
Dr. Madhuri, please introduce yourself.
Okay, I'm Dr. Madhuri Chandra. I'm from Bhopal. I'm a former professor from Gandhi Medical College, Bhopal. And
great to know about you, ma'am. And it was a pleasure interacting with you. Dr. Shama Kedar.
Yeah, hi. I'm Dr. Shama Kedar here. And I'm a professor and head at GMC Yavatmal in Maharashtra. Yeah.
Okay. Yeah, welcome you, ma'am. Dr. Sandhya Rani Panigrahi.
Ma'am has not joined yet.
Okay. So, ma'am, proceed with the panel.
Yeah, so myself and Dr. Parul today will be discussing common cases that we, it's like a recap of all the
Ma'am, please come nearer to the mic.
Yeah, it's like a recap of all the cases that we have, had talks about. So these are very common scenarios. So see, the significance, like Dr. Kiranmai was talking about, is that the maternal suicide in UK is the leading cause of direct maternal death. And if you look at in Indian statistics, the Kerala is the place which looked into the perinatal suicide rate. And because of increased care in other aspects like hypertension, diabetes, and all, this reason for death is coming down, and with suicide. So that is I just want to highlight the importance of this course and topic that we need to really take into consideration. So the first case today I'm presenting is she's a second gravida with one previous neonatal death. First pregnancy, it was an absolutely uneventful antenatal period. It was a routine. She came in labor at 39 weeks. She had a normal delivery, and it was a male baby of 3.4 kg with good Apgar score. And the following day, we just discharged her. And she was actually with her in-laws and husband here because her parents live in a small place. So she wanted to have a delivery safe in a good place. So then after the 10 days, she left her to the hometown, which is a small place. So she came after a month to the OPD, and she was looking sad. She came with her mother. She was looking. She was not talking much, looking sad. So and then on history takings, they said that the baby died. So I was very surprised because it was a very low risk pregnancy and a normal low risk delivery. So and so now so after, and they said it was SIDS. And at that point when I tried to talk more about, and then tried to assess whether she needs any screening for mental health and referral, her mother is like, no, she'll be fine, we'll take care of her. And she was very reluctant about seeking any help. So now in the second pregnancy, she conceived after 1 year. She had regular antenatal checkups and all her investigations, her blood sugar monitoring, scans, everything was normal. And but at every antenatal visit, she appeared very anxious and she had multiple unscheduled visits to the hospital. She's always concerned about the safety of the delivery. And at the time of at full term, she's very strongly requesting for a cesarean section. She always has that guilt, thinking that something wrong might have happened at the time of delivery. So this that the baby is not fine after delivery. So she was very extremely anxious and constantly requesting for a planned cesarean section. So I would like to ask one of the panelists, Madam Dr. Madhuri, there's a condition which we call as tocophobia, where they have a constant fear of childbirth. So as an obstetrician, when in this case, there is a situation that she had a neonatal death, but sometimes we also see that there are women who come and just say that because of fear of childbirth, we want a C-section. So how?
Can I answer that?
Yes, ma'am.
So this is a very pertinent question, and the thing is that this fear of birthing, like vaginal birthing, it can be primary or it can be secondary. Like in this patient, when she had a trauma because of the SIDS, she probably is blaming birthing as the cause. So this is called, I think, tocophobia, as you said it very rightly. So this is one fear of childbirthing which is ingrained in the woman, and that needs to be addressed. We need to actually talk about it. We need to understand the issue as to why this happened to the lady, and always say that, okay, your concern is very, very valid, and then maybe counsel her, this is something we need to actually talk it over. And in this, what helps is the antenatal visits and empathic attitude of the doctor all throughout the visits. So window shopping for the various doctors, various clinics, and changing doctors frequently, and not settling with the clinic, and because these are the things which lead to this anxiety getting enhanced. Now, if you settle down with one doctor you choose, and the doctor is empathic towards the patient's psychology, and antenatal counselings and antenatal sessions are held, and patient is counseled regarding the birthing and the causes of SIDS and possible causes of the trauma that she faced, it may help allay the fear. But if it does not, then maybe we can address it by offering her things like epidural analgesia, or we can take care of the pain part and the fear part separately, and then we can counsel the lady. Yes.
Basically, we need to understand what the cause of her request is and then counsel accordingly, I think.
Yeah.
Absolutely.
I would
May
like
I?
to call Dr. Sharma. Yes, Dr. Sharma,
Yeah.
what is your take?
Actually, thank you for letting me in. Actually, what I want to suggest here is, though it is a secondary tocophobia right now, but why there is a pain, why there is a fear, we have to analyze that first. And basically, she is saying maybe she had a phobia of something else, phobia of like fear of pain, fear of being touched by, or fear of doctors also. So there are various types of fears. We have to see to that whether it is PTSD, the post-traumatic stress disorders or not. We have to screen that first, and then we have to
Dr. Sharma,
alleviate.
what screening tools would you advise to all the
There
participants?
are various screening tools. They have given like screening GAD7 and all these things. one can do that. The fear scale is there. 0 to 10, you can use it. And in that scale, if you try to analyze her, what type of fear she is having, and whether you have to counsel her accordingly, and then if you are okay with elevating her fear, then we can give her a tour of our how we can go ahead with the vaginal delivery, and whether how it is safe, and rather what problems can occur with Caesar. Though Caesar is safe, we always tell them, but what problems, rare problems can occur, like a traumatic PPH and all these things. So I think we should elevate her fear first.
Thank you, Dr. Kedar. Dr. Madhuri?
Okay, I'll also jump in and give the obstetrician view. I think first of all, we need to talk to the patient. We need to get her perceptions on why she thinks that she had a loss of the first baby. Okay, why does she think that going in for the baby died at the age, it was a neonatal at the age of 1 month? So how does she correlate this with wanting a C-section instead of a normal labor? She had a normal labor with a 3.4 kg baby, male with a good abgar. So how we need to understand her perceptions also. We need to know why she's thinking that going in for a C-section this time will have a good outcome in the would not result in a neo. Okay, once we understand this, we need to give a certain information. One is that you had a apparently normal pregnancy, you had a normal childbirth, the baby was a good weight, then also you had a good afkar, everything went smoothly. So maybe the neonatal is not linked to your labor. Okay. Next, we need to tell her, give her a little information on what possible problems could arise. What are the advantages of going in for a normal labor? What are the disadvantages of a normal labor? What are the advantages of a C-section, and what are the disadvantages? Then we need to, I think, tell her a little about childcare also. In the first month, we need to talk to her. Was she breastfeeding properly? We try to take some questions, give her, direct questions also, not only the open-ended ones, but direct questions also on what exactly happened with the baby. Was she able to breastfeed properly? Was the baby sleeping? What were the circumstances that led to the death? It is written SIDS. It's a sudden infant death, but maybe when we go into details of it, we may be able to pinpoint that she may not have been able to breastfeed properly. The baby may be losing weight. The baby may not be urinating properly. The baby may not have had fever. Let us get the history out of her and then give her suggestions.
Thank you, Dr. Chandra. I want to just once again ask Dr. Kumar or Dr. Kedar, any role of psychiatry? Since we are on perinatal mental health, so how would you be able to refer her to a psychiatrist or therapist? Or
so that's so true that if you are assessing the lady on this general anxiety disorder or on patient health questionnaire, and you find that the condition is really severe, then a psychiatrist's assessment may be necessary for screening for maybe anxiety disorder, pre-existent depression, any PTSD, or any past history of any trauma or abuse trauma. Of course, we just assessed by her history. And if there is any therapeutic intervention that may be needed, sometimes the patient may require medication for, there may not just be tocophobia, but there may be other apprehensions and anxiety disorder, pre-existent anxiety disorders. So cognitive behavioral therapy, or maybe a trauma focused therapy, or maybe some psycho reduction or medicational therapy may be required. And a subtle medication like SSRIs or maybe risk benefit discussions, if we do, we are able to kind of allay the anxiety of the patient and bring her to the platform that she may be ready to understand the options that may be available to her, and they may not necessarily be harmful to her.
Yeah. In pregnancy, we see a lot of women with generalized anxiety. So it is important for us to identify whether it is the normal anxiety which goes off with normal coping mechanisms, or if there comes the role of screening, where we need to screen whether it is, general anxiety, or is it something which needs a psychiatric intervention.
Absolutely.
Actually, what I want to suggest here is, if you are a obstetrician, and once the patient is very much good to talk with obstetrician, when we refer them to the psychiatrist, still in our area, wherever in government setup, and when we try to refer to the psychiatrist, they may feel ki something is wrong with me. So in that case, they might not open up with them, though psychiatrists are good counselor and they try to get it from them. But I think obstetrician should be more friendly and try to take out the whatever it is from them.
Thank you, Dr.
One of
Shama.
the
I think
reasons
very
maybe people are
pertinent point
screening
15
because
seconds
it's
of one sentence I wanted to say. We practice in an area, I practice in somewhere near Delhi University, and it's a very prime area, and there are a lot of coaching centers nearby, and the class is highly educated, and people understand the psychiatric part of the ailment. So sometimes referring to a psychiatrist here in our perspective, in our context, is relevant, madam.
Yes, I agree with you totally. No issues about that.
May
I'm
I
just saying
also interrupt?
some part.
It may
Yeah,
take
yeah.
one or two visits
See,
for us to
the
come in home, but
obstetrician remains the primary physician.
Yes,
The
yes.
primary has the primary role. But I think if she is so insistent, so anxious, maybe a psychiatric reference would help her.
May help her. Yeah.
I think there are two sides to this. One is that you do refer, but if they don't come to a psychiatrist, so I don't think the point of issue here is a referral. I think the point of issue is identifying whether there's anxiety and depression by the gynecologist and maybe treating it at that primary level if they are refusing to go. But I think the aim should be that she gets treated and gets healed.
Yeah, in which scenario you are working, that matters a lot.
Absolutely. India is so vast, so everybody
Yeah,
has different stories to tell.
yeah.
So I
Thank
would
you,
like
Dr.
to
Varalakshmi. Would
go,
you like
yeah,
to
I would
add
like to
anything?
go on to the next question to the
Yes.
obstetrician. How feasible is it in your routine practice to screen for depression and anxiety in pregnancy, and what might be the barriers in our scenario, Indian scenario?
So in my context, well, it is very much feasible. In fact, we have several programs. We have antenatal programs wherein we have a counselor, dietitian, and a physiotherapist ingrained to our antenatal program. Here we do assess the psychiatric condition or the psychological analysis of the woman. We do assess, but simultaneously it does require adaptation. We have to look at the various skills, and assessment has to be done in cases where the women are not behaving normally. But how to implement it is a challenge. Like what we do is, in the first antenatal visit we are assessing. Again, we assess it in the middle of the second trimester or in the late third trimester. In the postpartum visit, we do assess. And when the visits are happening post delivery, again, we assess the woman, how accepting she is to the baby. Sometimes they are like, they don't want to see the face of the baby. They are so traumatized by the delivery, or they don't want to breastfeed the child, or they are, that sad behavior or rejection, and the desire not to room in with the baby, they don't want to room in easily. So that has to be detected, and kind of we are doing it regularly. But then there are barriers to this kind of screening we face, and sometimes we have a in-house psychiatrist also. We do require the help of the psychiatrist, and we do take it.
Yeah.
So I think the point here is that we need to routinely screen all pregnant women, like how we screen for hypertension, diabetes in pregnancy. In many places, I don't think that is still happening. And also, like yesterday's one of the talks in screening, they were saying lack of resources, where we not every hospital has a pathway where we can refer them to a perinatal psychiatrist, because not all psychiatrists who are specialized in perinatology, because it's very important. The question comes about the safety of the drugs during pregnancy and breastfeeding.
Agreed.
Yes, I agree.
Can we move on or to?
Yes, Dr. Varalakshmi, it would be nice.
So basically to summarize, the screening tools, it should be relevant to the place, short and quick to administer, because like yesterday's presentation, again, they said that in busy OPDs, there is something called Wooley's classification and GAD2 classification. In fact, I actually wanted to, share the one of the slides from, Telangana, the place where I work in Telangana. The government has introduced GAD2 and anxiety screening in the routine, the card where the government card has, which is very good. So the ANMs at every visit, they ask these two questions about anxiety and depression, and they identify high risk. I think that is a way forward to screen all the pregnant women to identify and then do appropriate referral. So
and I think the more we should be identifying with the second pregnancy or with the patients of BOH, more precisely we have to take care of such patients.
No, I think it has to be a universal routine
Yes,
screening,
yes,
right
you
from the
have to
first
do,
booking.
but more you have to concentrate on such patients also. If you are a
No, they are high
lack
risk
of
women.
resources, yeah.
So, do we have time for another case or?
2 minutes left.
Ma'am, you can take 5 minutes. That's all. You can quick do it fast if it's possible.
So this is a case of a previous, a woman with past history of psychiatric illness. She had, during her teenage, she had very aggressive behavior, and then she was started on psychiatric medication. She was on and off medication. And then just prior to marriage, she just stopped thinking that, it's a very common scenario. Prior to marriage, they don't want their in-laws to know. So she just stopped the medication. And post marriage, she became very aggressive, had a fight with the husband. And then they took her to a psychiatrist. Then they restarted her on medication. And then she became pregnant. So as soon as she's pregnant, everybody said that, these medicines are not safe in pregnancy, and suddenly stopped all the medication. The psychiatrist also advised, because you're pregnant, don't take any medication, counseling should be fine. But then at around 9 weeks, she came to the emergency department with a very aggressive behavior. So she had to be given haloperidol and then referred to an emergency psychiatry referral, and then restarted on the medication. So as obstetricians, how do you deal with this emergency situation? Because we are not well versed with this medication. And also as a psychiatrist, Dr. Parul, do you, at the initial visit, what is haloperidol the right medication to give in emergencies before? Because it will take some time. In the middle of the night, they come, the psychiatrist may not be available. So
Something is better than nothing, Dr. Varalakshmi. So injection
what is
haloperidol
ideal?
is I wish there was an ideal answer for this. There is no ideal tablet. All tablets, to be honest, now are safe in psychiatry, except for some mood stabilizers, which are basically neurological tablets. So you have the sodium valproates, the carbamazepines, and lithium, which are considered unsafe. Rest, everything is safe. So I would advise that please don't stop any medication. Unfortunately, many of them are on polypharmacy, so maybe reducing them would be a good idea. But injection haloperidol would be the treatment of choice, as well as restarting her medication, because withdrawal of medicines also causes side effects. And it looks like this lady had a mood disorder. So stopping everything further worsen the scenario. So I think not only for gynecologists, even for psychiatrists, the general rule is that we shouldn't stop medications unless, of course, there is some major side effects going on. In fact, they are safe not only in the first 3 months, but even later. So if somebody is having depression, anxiety in between, it's worthwhile taking antidepressants or anti-anxiety. Benzodiazepines for a very short period, not for a long period. But haloperidol, in fact, have been even tested on humans because this was before the ethics. So they are considered the safest as compared to the atypicals. So I would say, please, let's not stop medication for psychiatric patients. It's a myth that stopping them can cause severe side effects, or one should stop them because one is pregnant.
I would say here a preconceptional visit would have been very welcome, wherein you kind of involve the obstetrician and the psychiatrist, and you
Together,
shift over
yes.
from more harmful drugs to safer medications, and then probably plan pregnancy. But then, of course, these are those psychiatric patients where nothing is like, you cannot really always pre-plan. But if it is possible, then the best thing would be a preconceptional visit wherein you are able to assess. And sudden stoppage is a disastrous.
It's the worst thing. Yes.
Yeah. It should never be done.
Any further? Dr. Madhuri would like to add something on this.
Dr.
should we-
Shakuntala is quite right that we should have given her pre-pregnancy counseling. But even right now, if she's come at 8 weeks, she's come in the first trimester. We can still counsel her, tell her about the fact that the medicines should be taken at the right time. They are for help. They will not harm her baby. Maybe we can start a routine folic acid supplementation here. Okay. And pinpoint certain trigger points that cause her to go into, and how to avoid those trigger points also. Counseling not only should involve her, but involve her husband and her in-laws also, with whom she's saying, because sometimes they may be the ones causing the trigger points for her to go into that sort of behavior.
Or telling to stop medication.
Here I would definitely think that this patient requires a psychiatric referral.
Yes, right, spot on, I think. And so how often do you all feel she should go to and see a psychiatrist?
See, if we are calling her once a month, in the first 7 months that is routinely done, I think she should go to the psychiatrist also at least once a month.
I think Dr. Varalakshmi and I were on the same page. I said, at least let them come once in 3 months, if not once a month. Varalakshmi said, no, let them go to the psychiatrist if they do come to a gynec. It should be a regular follow-up. And I appreciate that. It would be good.
What I just want to add here, we have to counsel her in such a way that she should be going to the psychiatrist.
Yes.
That is
So
the
I think
role
the
of
onus lies on the gynecologist and not on the
Yes,
psychiatrist.
we only can make them go to the psychiatrist.
Yes. And I think that's why these kind of panels are important. So we
And do all the simple tests, especially the sugar test and all that. I have seen patients who become very aggressive when their blood sugar drops. Okay, so we are supposed to test them for their blood sugar with oral GTT. Here is one patient on whom I'll definitely do that the first time.
Yeah.
So I think there is very common, they have myths around drugs. So that has to be reiterated both by the physician and the psychiatrist, because that's most important to continue the medication through pregnancy as well as breastfeeding.
Yeah, Dr. Varalakshmi, may I now request for the take-home messages?
One last take-home
Just a word
messages.
before you do the take-home
Yeah,
message, Varalakshmi. It's just
Yes,
that
yes.
we also have some Garbh Sanskar classes in our antenatal programs. They are ingrained in these antenatal programs, and they really help in tiding over all the psychiatric, like all the psychological fears and all the anxieties that these girls have. And these programs, they really help in women in, paving way for a healthy pregnancy. And they have, like these are combined with the dance classes and done by the very qualified physiotherapist. So we have these Garbh Sanskar classes along with the dance classes, along with the dietitian, along with psychologists. So these combined together, we have a very good program wherein the outcome is not I can just say that the post-delivery times, whatever those postpartum blues are there, we are able to allay them to some extent. So I think these are important things.
Thank you. Any last few words,
Yeah,
Dr. Sharma, Dr. Madhuri, and Dr. Varalakshmi?
Thank you to all the panelists. That was a very good discussion.
They need to be handled with care. Joint consultation with the obstetricians and the psychiatrist should be there. They should be counseled on continuing their medication, supplementing with the multivitamins that are normally done in pregnancy is a must for these people. And then we have to tell her something about what is going to happen during delivery, and a little bit about childbirth and breastfeeding also. Take the opportunity in the antenatal period only to counsel her.
Yes.
And again, emphasize that she can continue her drugs even during breastfeeding.
Yes. I think good
Yeah.
take-home messages. Anything last words, Dr. Sharma?
Just what
Okay,
yes,
Sharma, go ahead. Go ahead, go ahead.
Yes, the most important, yes, is the obstetrician for any patient. And if obstetrician counsels her, she is ready to go ahead with whatever treatment if she has a faith in that her obstetrician. That is very important. And if she obstetrician feels yes, she needs psychiatrist help, she should go to the psychiatrist and she should make it sure that she should be going to the psychiatrist and getting whatever treatment is necessary for her at that level of the pregnancy. That's what I want to say.
Thank
And
you.
I would like to thank you, Dr. Mane, for letting me here in this such a prestigious panel and your program. Thank you, ma'am.
You're all of you are selected because you are all our experts.
Thank you, ma'am.
Okay. So
Thank you, Dr. Sheila.
Yes.
And lovely to
Thank
see
you.
you.
Yeah,
Lovely
yeah,
to see
Madhu.
Yeah,
you.
thank you so much, Dr. Parul, Dr.
Thank
Vera
you.
Lakshmi,
Yeah,
all
very,
the
very,
panelists. You all have
very, very
agreed to
nice.
join.
It
Yeah,
was,
thank
it
you
got
so
delayed,
much.
but
I wanted
I
to
think
just add
we
one
should
very
start sharing the link. Meanwhile, we
yes.
can talk.
We can.
Yeah,
I
And
just
please start
wanted
sharing
to
the link.
say something
Shreya,
very
share the link.
important is that why are we doing this panel? We are doing it not only for the mother, we are doing it so that she is treated and the intergenerational trauma stops. So she is not undiagnosed, untreated depression because
The
she
link
is
has
going
been
to
shared.
her children.
Share the QR code as well as
QR code, please. You can also share the QR code.
and Shashi, they want us to discuss that answer, sir, at the end.
Yes, 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 yes.
Like how we do. So it was really nice. See, like with Dr. Surekha Thade, we started that program, antenatal assessment. I was also part of it. So in that, what I felt, like I added a history of epilepsy to that. Because most
Okay.
of the patients, they don't reveal that history. They will be on medication, then suddenly they stop. So I thought when we are asking that, we can also ask them because these epileptic patients will have some sometimes low IQ, and they suffer with anxiety, depression, all those things. And what I have observed in South India, at least here in public sector, that history is always hidden. And it comes as a shock when she develops during antenatal period or during delivery. In the chat box also you share and all of you can start answering. And I really thank AICC RCOG for collaborating with us for this wonderful program. It was a lot of learning. As now there is a request. Yes, I am going to come out with a ICOG campus and I need help from all of you to come out with a booklet, and we shall release it sometime, and then we will make it available for all the FOGSI staff. Thank you, Dr. Parul and Dr. Lakshmi and everybody.
Thank you.
And I think it was a wonderful discussion. Real case scenarios makes it very simple and the people can understand it also. So I hope all of you have started answering the MCQs.
Thank you.
Thank you, Dr. Varlakshmi. Thank you, Shakuntala. Thank you, Kiran. Thank you, Kshama. Thank you, Madhuri and all. Jairani and Kiran Mai as well. Yes, hi, Rama. Kari.
So we look forward to having all of you back with us tomorrow for day 3 of this course.
Yeah.
And yeah. So thank you very much.
Shreya, post the link. Have you post in chat box? It is there.
Yeah, in chat box it is there. Please, can you share the QR code also in chat box? Yeah, okay. Please wait, don't leave. We will discuss the answers also.
Yeah, they want it because yesterday.
Yeah, they wanted. Yeah. It is required, in fact. You know that every talk and panel, everything was so excellent that I could not stop anyone, even if they have overshooted the time. It was so good content. Ma'am, please unmute yourself. Sheila ma'am, please unmute yourself. Dr. Ipshita has submitted.
Those who have attended, requesting all to spread the word about this, they can access it after a week on ICOG website. All the details, the whole program will be there on ICOG website. So the colleagues, those who were not able to attend, can always have a look at it. Chat box में डाल दो शशि message.
Okay. Ma'am, when shall we start discussing the answers? Only one message has come so that it has been submitted.
After it
Yeah,
is
two messages.
over, the time will be up, no? Once they
Okay.
stop sharing the questions, after that, they will put the answers. All of you can go to ICOG website in the beginning of the month to watch for the programs. Dates, everything, okay? The Guru Mantra, Master Class, then we also have certificate course. Then we have ODC for medical teachers, PG programs. Everything will be there on website. The whole timetable will be put up on the website for the whole month in the beginning. And all of you are invited to Bangalore for a national ICOG conference on 21st, 22nd, and 23rd of August. Actually, I wanted to share that brochure. From tomorrow, at least, Shashi, remind me, no, we should share.
Right, ma'am.
As well as those who are eligible for FICOG. Again, please access the website, the link, and apply for FICOG. There will be a
Yes, in fact,
in Bangalore also.
yes, in fact, we encourage all delegates who have not yet
please
been divided with FICOG, please apply for this. It is a type of national recognition. Somebody is asking for yesterday questions, Dr. Wasavi Mumana. What about this, Poonam?
We can't share yesterday's, but the questionnaire, we can put it on the website. Later on, you can see.
Okay.
You are welcome, Kiran, and come to Bangalore, Kiranji. MICOG, there are criterias. You have to be 3 years post at PG. You can and some publications. So please go to ICOG website and check for that. After receiving this certificate, the tool will be there available. I think those who have attended should start using it, so automatically the word spreads. MICOG is membership, FICOG is fellowship. For FICOG, the criteria are different. So you have to go and see. You need 3 publications and 3, you should have attended All India conferences, 10 years of FOGSI membership. Please go through it. It's simple, okay? MICOG is there. You please check. Otherwise, I will see to it why it is not displayed. I'll check into that. Pratik, if you are there, just see. MICOG details are not there, I believe, on website. Raya, unmute Dr. Shashikabra.
Yes, hello. Actually, my internet connection was lost, so I joined from phone. Dr. Sheila Mane ma'am is muted.
Yeah, I'm
We are not
talking
able
to
to hear you,
patient.
ma'am. Yes.
I'm talking to patient.
Okay.
Those who were not able to do yesterday, do with wholeheartedly 2 days. Okay. Now don't bother about first day. Wholeheartedly do today and tomorrow.
Ten seconds left.
So I'm trying to join from my laptop again as internet connection has come. Please unmute me that time.
Now you can take the question, Shashi.
Yeah.
Only read the answer, okay, in that yellow, okay, yellow mark.
Yeah, please, you can display it on the screen.
The question and the correct answer.
Yes. The first question one was, which of the following is an appropriate statement to make to a grieving parent following a perinatal loss? The answer here is C. I am sorry for your loss. This must be hard for you. Then coming to question number 2, according to research, approximately how many women experience complicated or chronic grief after a perinatal loss? The answer is option B, 15 to 25%. Then coming to question number 3, during antenatal consultation, a woman subtly indicates possible abuse but does not openly disclose. According to best practice, which response reflects validate in the WHO LIFES approach? So it was discussed nicely today. So the answer is B, I believe you and you are not alone. Question number 4, all the following are red flags indicating possible domestic violence in a pregnant woman except. The answer is A, regular antenatal visits. Question number 5, a 29-year-old Gravida 3 Para 1 L1 woman of 18 weeks gestation is screened during the antenatal care and reports daily alcohol consumption with inability to cut down despite repeated attempts. She also describes cravings with withdrawal symptoms when she tries to stop. According to SBIRT model, what is the most appropriate next step? Here, the answer option is C, refer to a specialized de-addiction and treatment services. Question 6, during a routine antenatal visit, a woman denies substance use but reports that her husband smokes heavily at home. She has recurrent respiratory symptoms and poor weight gain. What is the most appropriate next step for the obstetrician? Here, the answer is option C, screen for second-hand smoke exposure and counsel for spouse smoking cessation. Question number 7, the de-escalation techniques include all of the following except. Here, the answer is option D, closed question. Question number 8, the E in the spikes protocol stands for empathy, yes or no? Answer is yes. Question number 9, the practice that is recognized as a best practice component of supportive care for parents experiencing perinatal loss is. Here, the answer is B option, that is, providing opportunities for parents to hold, bear, and create tangible keepsakes, as for example, footprints, photos, locks of hair of their baby. Question number 10, when delivering news of a fetal anomaly during an ultrasound, which strategy best supports the patient's emotional well-being? Here, the answer is option C, use clear, simple language, pause to allow the patient to process the information and then acknowledge the emotional impact. Question number 11 is regarding the domestic violence, screening in a routine OBGYN visit, which communication standard is essential for patient safety? Answer is option C. Conduct the screening in a private, confidential setting away from family members or partners. Question number 12. Why is it important to assess the patient's perception before delivering bad news? The answer is option B. To gauge what the patient already knows or suspects about their medical condition. Question number 13. During the emotional empathy phase, what is the best response if a patient begins to cry? Here the answer is option D. Allow silence and offer support, acknowledging the patient's distress. Question number 14. Which of the following best describes the psychological phenomenon often experienced by parents following a perinatal loss? Answer is option A. A linear, predictable progression through 5 distinct stages of grief that always concludes with acceptance. Question number 15. Tobacco smoking during pregnancy is strongly linked to which specific obstetrical outcome? Answer is option C. Intrauterine growth restriction. We also call it fetal growth retardation, FGR. Question number 16. Which of the following is considered a normal component of perinatal grief? Here the answer is option B. Temporary sleep disturbance and sadness after pregnancy loss. Question 17. A 28-year-old prima gravida expresses intense fear of a vaginal delivery and requests a cesarean section despite no medical indication. What is the most appropriate first step? Here the answer is option C. Explore her concerns and provide counseling. Question number 18. Tocophobia is best defined as. Here the option is answer C. Pathological fear of childbirth. Very common. Then question number 19. Which of the following is an important component of counseling in tocophobia? Here the answer is option C. Multidisciplinary approach including mental health support. And last question number 20. Which condition is commonly associated with secondary tocophobia? Here the answer is option A. Previous traumatic birth experience. Hello.
Yeah, I think shall
Yeah.
we
Thank you.
move
We
to
are
now
done. Yeah.
Yeah,
propose?
just let me give the vote of thanks.
Yeah.
Yeah, so I respected dignitaries, esteemed faculty, and dear participants. I begin by expressing my sincere gratitude to Dr. Bhaskar Pal, President FOGSI, Dr. Suvarna Khadilkar, General FOGSI, Dr. Sheila Mane, Chairperson ICOG, Dr. Sadhna Gupta, Vice Chairperson of ICOG, and Dr. Pratik Tambe, Secretary ICOG, and Dr. Ashok Kumar, Chairperson elect of ICOG, for the opportunity to conduct this program and for their thoughtful guidance throughout. I would also like to extend a special note of thanks to Dr. Parag Beniwale, immediate past president of ICOG, for his valuable support and encouragement. I extend my heartfelt thanks to our convener, Dr. Uma Ram Ma'am, for her inspiring leadership, constant encouragement, and support. My sincere appreciation to our dedicated coordinators, Dr. Kiran Pandey Ma'am. I give a lot of respect to her. Madam, I worked with Ma'am in Medical Education Committee, and Madam is just awesome. My special thanks to Dr. Deepa Gupta, my colleague, whose meticulous planning ensured the smooth conduct of this program. We are deeply grateful to our respected chairpersons, Dr. Tamkeen Khan, Dr. Manju Puri, Dr. Jairani Kamraz, and Dr. Kiranmay Devinani for guiding the sessions with their expertise and insight. A note of thanks to our esteemed speakers, Dr. Asalesha Bagadia, Dr. Varalakshmi Nandial, Dr. Lakshmi Shiva, Dr. Uma Milikineni, for their excellent deliberations on important and sensitive topics like perinatal grief, breaking the bad news, trauma-informed care, de-escalation skills, and substance abuse. Your insights have truly enriched our learning. We also thank our moderators, Dr. Parul Tank and Dr. Varalakshmi, along with our distinguished panelists, Dr. Shama Kedar, Dr. Madhuri Chandra, Dr. Shakuntala Kumar, and Dr. for a very engaging and thought-provoking panel discussion. And I'm really thankful that they agreed to join the panel on a very short notice. I would also like to acknowledge all our participants for their enthusiastic involvement and keen interest, which made this academic program truly meaningful. Last but not the least, I extend our sincere thanks to the entire organizing team and the support staff who have worked tirelessly behind the scenes to ensure the seamless execution of this event. With this, we conclude day 2 of this enriching teaching course. Thank you so much.
Okay. Thank you,
Thank
Shashi.
you, Sheila
I
ma'am.
think
Thank you.
thank you, Anita. Thank you, everybody. Thank you, Kiran, for being there. I think you can stop the recording, Shreya.
Yeah.